Good morning, everyone, and welcome back to day 2 of the 4th International Journal of Medical Students, IJMS, World Conference of Medical Student Research 2025. My name is Elaine Liang, and I'm a second-year medical student at the Kaiser Permanente Bernard J. Tyson School of Medicine in Pasadena, California, and I'm honored to serve as this year's Masters of Ceremonies. Yesterday, we heard 26 inspiring presentations from medical students across the globe, from Ukraine to Bangladesh to Palestine, each sharing research driven by passion, curiosity, and a commitment to advancing medicine. It was truly remarkable to witness such diversity of ideas and the global spirit of collaboration that defines our medical community. Today promises to be just as exciting. We are thrilled to continue with our final round of oral presentations, followed by 2 rounds of poster presentations, which we are proud to introduce to the conference this year. At the conclusion of today's program, we will also be announcing our award recipients, and we look forward to celebrating all the hard work and dedication that brought us to this moment. I would now like to invite Chloe Carrington, director of this year's conference, to share her Day 2 opening remarks. Welcome, Chloe.
Thanks, Elaine. Good day, everyone, and welcome back to the International Journal of Medical Students' 4th Annual World Research Conference of Medical Students. I am Chloe Carrington, a second-year medical student at the University of Queensland-Oshner, and your director of the conference. What an incredible journey it's been so far. Yesterday, we saw ideas that challenged the way we think, research that pushed boundaries, and conversations that reminded us why curiosity is the lifeblood of medicine. Today, we bring the same energy into our final sessions, a chance to celebrate not just the science, but the people behind it. To our presenters, you've already shown remarkable dedication, balancing the demands of medical school with the rigor of research. Today is your moment to share your hard work and leave us inspired. I also wanted to personally thank the judges, my conference team, the IJMS student editors, and my other journal members who are responsible for the marketing, logistics, and assessment of every single presentation and abstract submitted. Your hard work and care is what made it possible to celebrate our presenters and their wonderful research. So let's make this final day one to remember. Let's celebrate loudly, engage deeply, and carry forward the connections we've built here. Presenters, it's your time to shine. When it's your turn to present, turn on your mics and cameras to share your research on this global stage. You'll be sharing your screen, so have your slides and posters ready. Judges, please ask a question after each presentation and consider the thoughtful responses that you receive from the presenters. Audience, please vote for your favorite presentations by scanning the QR code and filling out your ballot. With that, let's dive into our final day together. Here's to discovery, collaboration, and the lasting impact of medical student research.
Thank you, Chloe, for your thoughtful remarks. And now it is my pleasure to begin our first session by welcoming our judges. Our first judge is Dr. Dimash Davletov from the Kazakh National Medical University. Our second judge is Dr. Avi Singh Gand, a neurology resident from Emory University. And it appears that our third judge is not here yet. Welcome, judges. Now, without further ado, we will be presenting with our first session of oral presentations for the day.
Hi, everyone. I'm Ariel Davydov. I'm a third-year medical student at the University of Colorado, and my screen is shared. I'm not sure if it's popping up on the big screen there. There we go. Awesome.
Yes, awesome. Yeah,
Perfect.
You are perfect and ready to go.
Awesome. Well, thank you so much, everyone, for having me. I am beyond thrilled to present my project ECHO, which stands for Exploring Careers in Healthcare and Onward. And this is a community outreach program that's geared towards increasing healthcare career interest in K-8 students surrounding the CU Anschutz Medical Campus in Aurora, Colorado. And to start, I'll kind of talk about what informed this project, and our overlying tenet is early exploration can strongly influence children's career development. There's been past research that has suggested that children from low socioeconomic backgrounds have a relative lack of exposure to the healthcare environment, and that's been adversely associated with healthcare career interest. There have been numerous pipeline programs and studies that have really attempted to address this proactively through programs, that are really geared towards addressing the shortage of healthcare professionals in low socioeconomic communities. But these have all been geared towards early adolescents or teenage adolescents and high school students. We don't really have a program like this for kindergartners, for third graders, for fifth graders. So in comes ECHO, and our program is designed to allow exactly that, to allow elementary and middle-aged students to, one, experience careers in healthcare and facets of clinical practice, and also learn about basic physiologic concepts that inform our practice through interactive and engaging hands-on experiments. And the hope is that these projects, they're geared towards this mission, and hopefully they can increase exposure and interest in healthcare careers in this population, and ultimately strengthen the pipeline for diversity of the medical workforce and kind of feedback into, our system of different healthcare professionals in the Aurora community. The way this was designed, from December 2024 to October 2025, we offered 4 career fairs at local libraries and elementary schools in Aurora County in Colorado. And all of these were at partnered schools and libraries in neighborhoods surrounding the medical campus, many of which have many students that qualify for free or reduced price lunches. So this is definitely an underserved population. And through these events, we offered a regimented curriculum that featured 4 activities that were centered on various body systems and medical specialties. And these were developed with the intention of highlighting a body system that children could easily identify, like the brain, the heart, the lungs, and also highlighting a facet of clinical practice that we tend to do, on a daily basis, like listening with a stethoscope or using a reflex hammer. And the 4 activities we offered are: 1, build your own stethoscope, where, as you can see on the screen, children would use a toilet paper roll and a funnel to make their own stethoscope, listen to the heart at rest and after exercise, and tell us what they hear. They would make a lung model using straws and balloons. They would make a surgeon's bracelet, which is, a bracelet using the 2-handed tie, what we use in the OR to close cuts. And they made their own reflex models and practiced deep tendon reflexes, but specifically the patellar reflex, on volunteers, of course, with supervision. All of these activities were led by medical students and training physicians from the University of Colorado. So really offering, that mentorship and one-on-one connection between our campus and these young students. And following the completion of the fair, we surveyed all participating students with anonymous post-pre surveys that really sought to evaluate their interest in healthcare careers before versus after the intervention. And what we found was pretty overwhelmingly positive. We had 71 elementary and middle school students participate and be surveyed over the past year. And there was an 175% increase in yes responses to the question, I'm interested in a career where I grow up to be a doctor, following the event. And as you can see here, the yes response, spikes up pretty significantly. And that result was significant. Our P was 0.0045. So we really are seeing, there is an immediate response to these activities, at least in a general sense of, reacting to these events and, responding with increased healthcare career interest. We also asked them about their favorite activities that they participated in, and if those were related in any way to a profession in that related specialty. And the relative popularity of activities followed the same pattern as reported interest in specific careers in medicine. The surgery activity was most popular, so was the surgery profession, followed by cardiology, neurology, and pulmonology. So you're really seeing these kids, even though they're super young, they are really making these connections and seeing, I'm interested in cardiology, so maybe, or I'm interested in this activity that's highlighting cardiology, maybe I want to be a cardiologist one day. And we also asked them why they chose their favorite table, and the most frequently cited reason for why that was the activity was most fun. So definitely seeing factors such as fun and engagement really inform their interest, and as a result, their response and reaction to a potential career in healthcare in the future. And in conclusion, we found that our post-pre surveys, they demonstrate a significant increase in healthcare career interest following completion of the one-off ECHO career fair intervention. And this demonstrates the ability of such an intervention to immediately impact vocational aspirations in elementary and middle school students. Some limitations of this is, students are, since they're anonymous surveys, we survey them immediately after. We don't really have surveys that stretch out to several months after the event. So we're not 100% sure if this is longstanding, but what we do see is there is a significant positive response to healthcare career interest following engagement in such an activity, especially in elementary school students, which prior to this, things like this did not exist. So this is super exciting and really cool that we found a way to really reach this community in this way. But ultimately, by offering opportunities for students surrounding the Anschutz Medical Campus to engage in healthcare career-oriented learning experiences, our hope is that ECHO can empower youth to pursue careers in healthcare in their professional futures, and hopefully have some fun along the way. These are our references, and we've actually uploaded the curriculum to 2 online learning educational platforms, and you can scan this QR code to our site on Merlot if you're interested in seeing what our program looks like on a day-to-day basis. Thank you, everyone.
Thank you for that excellent presentation, Ms. Ariel Davydov. And we really appreciate your last minute sort of switch and just moving quickly with that. So now we'll be opening up the floor for questions from our judges. Liang, go ahead, judges. Yeah.
Hi, Ariel. Great presentation, I think. Someone who's passionate for med ed. I really felt great the fact that you've kind of targeted a very young population from the very early stage, which I think is unique. I do have a question. Do you think that through this research, we're definitely gathering their interest, kind of also tilting them if they want to pursue medicine in the future, but how much of that necessarily translates into, oh, cardiology it is for me because it's fun, but is it still going to be cardiology at the end of the day? And I think the primary endpoint still is very relevant in the sense, like, if they are going into medicine, regardless of what they end up choosing, is also remarkably important. But what is your take on if that translates into what they ultimately might end up still be interested in? Because I'm sure at this stage they have a very narrow understanding of what that specific specialty entails.
Totally. I think that's a great point to bring up. I think our primary endpoint here is just interest in healthcare careers at large. Is this something that changed following the intervention? And I think something that we looked at in addition to that, these additional variables were, like, are they interested in cardiology? Did they like the table? I think those variables were a bit more exploratory. And honestly, from my perspective, wanting to see if that was something that children at this age could even grasp, if they could make that connection of this table is interesting. So as a result, I might be interested in this career. While we're not necessarily sure if that will translate to a future career in cardiology, what we are seeing is that this curriculum has the potential to elicit that kind of interest immediately after, not necessarily long term, but definitely, we're able to make that connection. I think something that we can expand on in the future is surveying students at 6 months out, at a year out, to see if this is longstanding. I think that's probably the biggest limitation of this kind of setup. But the issue is also that all of these are anonymous, so tracking down these students can be quite difficult. But I think that's, a really important point to bring up. So I appreciate that question.
Perfect. I agree. I think it's a great intervention, but longitudinally following it up at different stages, I think would also add a lot of value, even in the context of if that medicine interest translates into pursuing medicine at the end of the day.
Totally.
Thank you.
Hi, Ariel. Thank you for your presentation. It's a really awesome job. I wish I had some project when I was a child like this. And actually, Dr. Singh, he asked my question that I was interested in, and you already told that you're planning to do a longitudinal follow-up. and that would be really great. But one more question. You mentioned that there was some significance in your statistical test, but I couldn't find any information regarding that in the methodological section. Could you please clarify what was the test you used to
Yeah.
see the significance? Thank you.
Yes. Yeah. So for the table in particular, where we asked them, before versus after, yes, no, healthcare careers, we made a 2x4 table and did a chi-square test, and the result was significant. Our P was 0.0045. So that demonstrated to us that this increase in yes response was a significant value. Additionally, I think the only other test of significance that we showed was the difference in responses for why they cited their favorite activity, and fun was the biggest one, and that P was significant as well. It was less than 0.0001.
All right. Thank you, Ariel. That's a great initiative. Continue your work. Thanks a lot.
Thank you.
Thank you so much, judges, for your questions, and also Ariel for answering them. Judges, go ahead and please feel free to take this transition time to submit your judging response form. We will now be displaying a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Now we'll be moving on to our first presenter, Mr. Jacob Bauer from Australia, presenting his original research entitled Sleep Solutions or Sleepless Nights, Adverse Events in Mandibular Adjustment Devices and Hypoglossal Nerve Stimulator Treatment of Obstructive Sleep Apnea. And we can hear you. Go ahead.
Great. Thank you so much for having me and for making that last minute switch. Again, my name is Jacob. I'm from the University of Queensland in Brisbane, Australia, from the medical school there. And this project was done in collaboration with my colleagues, Chloe Carrington, who's also from the University of Queensland, part of the Osher program at the medical school, and Sana Khan from the University of Texas Southwestern Medical School. So our research was really looking into obstructive sleep apnea and trying to characterize some devices which are used to treat that sleep apnea. And that's where we are looking at the adverse events of those devices and trying to characterize them. Just some background on sleep apnea. Obstructive sleep apnea is a serious chronic disease which is characterized by repeated upper respiratory airway obstructions that occur during sleep, leading to episodes of disrupted breathing, sleep fragmentation, and reduced oxygen saturation. This is a very serious cardiovascular disease, this is a very serious condition which can lead to severe knock-on effects for cardiovascular diseases, metabolic disorders, cognitive impairments, and premature morbidity and mortality. In the US alone, it's estimated that there's 30% of the population above the age of 20 years old who have obstructive sleep apnea that are not being treated yet. So the current landscape for treatment and how this is resolved is really, the mainstay is what's known as continuous positive airway pressure, and otherwise known as CPAP, which creates a positive airway pressure through continuous air in the nasal cavity to keep the airway patent. Now, there are other devices which are coming onto the market in response to some of the drawbacks which are naturally inherent with the CPAP machines. Things that have been cited are episodes of discomfort, bulkiness, and just lack of feasibility and compliance. While it is the gold standard treatment, these issues have led to a lot of interest in alternative ways of achieving airway patency throughout the sleep episode, so that there are no episodic closures of patency within the airway. One device is the mandibular adjustment device, which is one of the The two devices we're looking at in this case are the mandibular adjustment devices and the hypoglossal nerve stimulators, which achieve this by different means. The mandibular adjustment device advances the mandible to keep the airway patent, while the hypoglossal nerve stimulator has a implanted generator into the chest and stimulates the hypoglossal nerve directly to maintain tone. But there's been very limited studies which are comparing the safety of these devices in comparison to CPAP. Hence, the overall motivator for this project was to try and shed a bit more light. Hence, the aims of this and objectives of our study were to categorize the adverse events associated with mandibular adjustment devices and hypoglossal nerve stimulators in those with OSA who are using publicly available data, and to compare the severity of adverse events associated with mandibular adjustment devices and hypoglossal nerve stimulators, and to develop an understanding of the risks these alternative therapies may pose for patients with OSA who are intolerant to CPAP. The methods we used were a retrospective database analysis of the Food and Drug Administration's Manufacturer and User Facility Device Experience Database, or the MAUDE database. And we started by including key terms for the product names, which I've excluded from this presentation, but we verified which products needed to be included through product codes. And from 117 total, we removed 57 devices or 57 reports, and those reports didn't meet inclusion criteria for product codes, as well as we ensured that the reports that we were studying on these adverse events needed to be related to injury and not malfunction. If there were duplicates or serial reportings, then those were considered as a single event to minimize the impact of that. And after we had done that, we could then characterize and extract the data based on the type of harm and a set of patient outcomes, as well as then classify the severity of harm using the Cliven-Dindo scale. The methods for our inferential statistics were using a Fisher's exact test, and this was in part due to our sample sizes being smaller. And this allowed us to compare categorical variables for the type of harm, as well as the type of patient outcomes that we were looking into. So hospitalization and surgical management in that respect. We used a Cliven-Dindo scale to classify the adverse events based on the severity of harm. And then a two-tailed, two-sample t-test, assuming an unequal variance between the groups, was used to compare between those two severity scores. The results, which we, from a total of 84 devices, which we analyzed, was that we found trauma was the most frequently reported adverse event for the mandibular adjustment devices, as well as allergic reactions were significantly more prevalent compared to that of hypoglossal nerve stimulators. And that was found at the p-value of 0.02. In terms for the hypoglossal nerve stimulators, pain was the most frequently reported and was significantly more prevalent compared to the counterparts in mandibular adjustment devices. Looking at the results a little bit differently, the hypoglossal nerve stimulators had an overall higher mean adverse event severity score compared with mandibular adjustment devices, a level of 3 versus 2.37. However, we didn't find any significant differences in rates of trauma, paralysis, or hospitalization. And finally, several outcomes in surgical management, dysphagia, and paralysis approached statistical significance for the hypoglossal nerve stimulator group being higher than the mandibular adjustment devices. However, they did not meet our statistical threshold. And I'll discuss about this later in our strengths and limitations. So what's the overall interpretation of our results? Well, we found that hypoglossal nerve stimulators were associated with more severe and more painful adverse events. The severity score, which we found to be higher, suggests that these hypoglossal nerve stimulators may carry a higher clinical risk due to the nature of them being a more invasive modality compared to mandibular adjustment devices. And in turn, we found that mandibular adjustment devices, while had lower scores, were more likely to cause allergic reactions. And this was likely due to material composition. However, that is just an interpretation. So some strengths and limitations from our study were that the data extraction process was carried out by 2 independent reviewers and was conducted in a standardized form. And that helped us ensure strong internal validity and enhanced our reliability, as well as minimized bias. And we used a valid classification tool as well. And that created a more robust internal validity for our design. However, some limitations were that we analyzed only a single database that was based in the United States, and that can limit the generalizability, as well as the fact that these reports that we were categorizing contained data which was voluntarily reported by patients, and that subjected our study to limited sample sizes, and we may have not been able to detect effect sizes such as that, as previously mentioned, with outcomes approaching statistical significance. So what are the practical implications, and what does this mean in clinical practice for us? Well, mandibular adjustment devices and hypoglossal nerve stimulators have distinct differences in their adverse event profile. And in educating patients and in helping make informed decisions, we need to counsel patients about these device-specific risks. For instance, specifically material sensitivity could be a consideration when prescribing mandibular adjustment devices. And on the flip side, when considering hypoglossal nerve stimulators, clinicians should take extra caution in understanding the implications of a surgical procedure and the limitations that may have for certain patient groups. And in total, further research is really needed to help shed even more light and identify the causal factors to improve the overall device safety, as well as how we can better treat these devices in a way that limits the harm to patients, as both of these devices were clear to show that they could have the potential to cause significant harm to patients, and they're not just benign treatments. These were the references for our study, and I'll open the floor to any questions.
Thank you for your presentation, Mr. Bauer. And so I will now open the floor for questions from our judges.
If it's okay with you, Dr. Davletov. Great job, Jacob. I think as someone in neurology, I think I have seen a lot of OSA patients, and it's a very under-recognized risk factor of strokes and everything that can arise from it. So I think it's definitely an interesting topic. What is your take? The one thing that I felt was it could have been helpful is getting an understanding of which people are candidates for MADs and HNS, especially since CPAP is conventionally the first line. And I understand that you've been kind of comparing the second line, or at least not the non-first line methods. But what is your take on just because HNS is an invasive procedure, right? It's a surgical procedure compared to MAD. How does that come into picture, as surgery itself will have inherent complications, right? So that might alter the picture.
Absolutely. And I really appreciate you asking that question. So, and I feel like a good way to answer this question is to share some of the details which we found in the raw data. For instance, in part of our categorization, we initially were looking at factors like previous cervical neck surgeries and other previous pharyngeal procedures that were done. However, because it was voluntarily reported, we didn't get enough data to really get a good picture of that. But in answering your question, individuals who I think have had multiple procedural attempts might be at a different risk criteria than those who've never had a procedure done with ENT. Likewise, naturally with the impulse generator, based on the diagram I had in the presentation, I can only assume that for having an implant that was in the middle of the chest, there were some reports about the uncomfortability of that. And so there might be certain patient demographics. There might be individuals with certain BMI characteristics which might not be able to tolerate an implant, even though it might potentially be more effective than a mandibular adjustment device. And on the flip side, mandibular adjustment devices, a lot of the time what we could see was that there was visits to the hospital for accidental ingestions of device components, and it only takes a stray wire to cause a bowel perforation. And so these are very important questions, and I'm happy you asked that, because it'd be really important to look at what sorts of patients would be at higher risks with each device based on the potential for harm that they could cause.
Thank you.
Hi, Jacob. Thank you for your presentation. It's a really good work. And I've got some questions. So you've already mentioned your limitations. It's sample size. It was really limited. And because of that, you showed that the MAD was 24 versus 60 in NHS. And there might be some, biases when you collect this data. Did you try to collect some confounders of these patients and maybe use some statistical tests like propensity score matching to, make the cohorts equal?
So in terms for propensity scoring and matching, it was really difficult because of the fact that the data was voluntarily provided. It was really very difficult to do that. And so our best means of trying to match that up was the severity score through the Clive-Dindo, because that was a pre-validated tool that would help minimize our potential for causing a bias, or even recognizing a bias in the fact that there are more scores. And so we took the average of those scores accordingly, and it was based on the amount of interaction with patient outcomes. So things like seeking interventions. So naturally, I understand our two samples were quite different in their sizes. However, we did see in both cases a significant amount of individuals who were going in for treatment interventions, and that's where both criteria were elevated. But it would have been good to try and find a different score. For instance, looking at a frequency of maybe a first line treatment or another treatment to try and get a baseline understanding of how many individuals normally would go in for any type of intervention, because they're using a device to at night while they're sleeping, and there's a risk. So to get a better understanding of that baseline, we probably could have done something else, but the best we could do was use the Clive-Dindo scale, I think, to minimize our own biases on that.
Okay, thank you, Jacob. Good job. Thanks.
Thank you so much, judges, for your questions. Please go ahead and take this transition time to submit your judging response form. And thank you for that presentation, Jacob. We will now be displaying a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Now we'll be moving on to our next presenter, Ms. Nguyen from the United States, presenting her original research entitled Association Between Diabetes Mellitus and Intraoperative Awareness During General Anesthesia, a Retrospective Cohort Study.
Good morning. Can everyone hear me?
Yes, we can hear you and see you. Please proceed.
Okay. Perfect. Yeah, so good morning, everyone. My name is Nguyen. I'm a second-year medical student from Drexel University, and today I'll be presenting my research on the association between diabetes mellitus and the intraoperative awareness during general anesthesia, which was a retrospective cohort study. This study was done along with my colleague, Zhenghao Wang, under the guidance of Dr. Espiradian. So just a brief introduction about intraoperative awareness. It's defined as the unintended recall of events under general anesthesia. It's a rare but remains a consequential complication which can lead to serious psychological and medical legal consequences, including post-stress traumatic disorder and even anxiety-driven. So we want to investigate this phenomenon in diabetic patients, which is defined as the metabolic disorder characterized by chronic hyperglycemia, either due to an autoimmune etiology, which is type 1, or insulin resistant, which is type 2, the more common form. So patients with diabetic often have a lot of side effects, and these side effects can interfere with the distribution of general anesthesia, such as altering the autonomic responses, being that it can blunt the physiological response when these patients experience intraoperative awareness, including tachycardia or hypertension. Patients with diabetes can also have a lot of microvascular complications, and this can lead to decreased tissues and blood perfusion, hence affecting the distribution of general anesthesia. So these are some of the complications that can occur with diabetic patients that may mask conventional signs of inadequate anesthetic depth. Because of this phenomenon, it warrants for more research into this growing population, which is why we investigated whether diabetes mellitus is independently associated with an increased risk in intraoperative awareness during general anesthesia. For our research, we utilized the TriNetX research platform, which is a federated healthcare network that includes data from 72 different healthcare organizations across the US. We use 2 different cohorts total. So there is a cohort with diabetes mellitus and one without diabetes diagnosis. Both undergo general anesthesia. And then we did a one-to-one propensity score matching to reduce any confounding variables. And some of the diseases that we balanced were hematological diseases, dermatological neoplasms. And the primary outcome for the study was the documented occurrence of intraoperative awareness, as indicated here using the ICD-10 code. Post-matching, we had a total of 387,736 patients, in which there's 193,868 in each cohort. So as you can see here, the risk for the diabetic cohort experiencing intraoperative awareness is 0.027%, whereas the non-diabetic cohort is 0.015%. So this leads to a risk ratio of 1.793. So that means that 79.3% people in the diabetic cohort experience this phenomenon more than the non-diabetic cohort. And the odds ratio came to be 1.793, which is the same as the risk ratio. And this is mainly because the event of intraoperative awareness remains a very rare phenomenon, as shown here. For the risk difference, our p-value is 0.01, which shows that the data is statistically significant, and the risk difference is 0.012%. So when this translates to real-life data, it correlates to about 12 additional cases per 100,000 cases. So this kind of further emphasized that intraoperative awareness remains a very rare phenomenon, but is still very clinically relevant because of the detrimental outcome that it can carry. So what this means in terms of clinical implications is that I just want to emphasize that even though the the absolute difference remains very small, it still is clinically relevant because of the psychological burden that it can have on the patients, such as anxiety, PTSD, and it can even prevent patients from reaching out for future healthcare in the future. So it's very important to recognize and mitigate the risk in this high-risk populations of patients. So some of the suggestions that we have is to consider the EEG-based depth monitoring when autonomic signs are unreliable, especially in these population of patients, because EEG allows for real-time assessment of the anesthetic depth. Next is the use of neuromuscular blocker. They are known to be able to mask the effects of patients showing signs of them experiencing intraoperative awareness. So it's very important for clinicians to use these agents cautiously or minimize them whenever possible while ensuring that adequate anesthetic depth is achieved. And last but not least is to implement structure post-operative recall checks to identify delayed awareness, as sometimes patients can take hours or maybe months or years to even recall that event of themselves experiencing the phenomenon. So in conclusion, even after rigorous control of adjustments for confounders, we found that diabetes mellitus is associated with a statistically significant increase in unintended intraoperative awareness during general anesthesia. So although this remains a rare phenomenon, this still highlights the importance of individualized anesthetic management and calls for heightened intraoperative vigilance in these high-risk population of patients, especially when the prevalence is for diabetes is continuously on the rise. And here are my references. Thank you. And I'll take any questions.
Thank you for your excellent presentation, Ms. Nguyen. So now we'll be opening the floor for questions from our judges.
Hi, Ngok. Thank you for your presentation. It was really awesome. The statistical tests were great. And I've got one question. I'm not sure. Did the data allow for like stratification by diabetic mellitus type, or maybe by the patient's level of hypoglycemia? And do you want to stratify in future to know the risks of different groups of these patients? Thank you.
Thank you for your question. So we gather the data using the ICD-10 code. So that was if the patient has the ICD-10 codes for diabetes, that's how we select them for the data. And this wasn't specifically chosen either type 1 or type 2, but for our studies in the future, that's a future directions that we could do is to stratify them to type 1 versus type 2 and see how the difference is.
Thank you. Good luck.
Thank you.
I think Dr. Davletov brings about a great point. As someone who's seen a lot of peripheral neuropathy secondary to diabetes, so much, clinically, one thing that becomes very relevant is not just how bad your hyperglycemia is. Your A1C helps you stratify that, but the duration of how long this person's had diabetes can also really affect like how severe their neuropathic symptoms are, and that as an extension can lead to people having autonomic neuropathy. And my understanding by your presentation was that is the understood pathophysiology of why these people have intraoperative awareness. So I think that would be a great way to proceed with it, adding stratification, not just based on type 1, type 2, but also like duration of diabetes and how bad was the A1C. My question for you would be, could you walk me through why did we use both risk ratio as well as odds ratio? I know that you mentioned them both, but what is your rationale there? Because my understanding is like, I know like retrospective or prospective cohort studies define a risk ratio, whereas a case control study kind of helps you come up with an odds ratio. But yeah,
Yeah, thank you for your question, and also thank you for kind of reaffirming that we should use the stratification. As for your questions, we use the odds ratio, so it basically kind of tells the risk ratio. So basically tells us that how much more common is this phenomenon in the exposed group over the unexposed group. So this kind of helps to see the difference in how much more common these patients with a diabetic group experience the intraoperative awareness. So it kind of gives us the percentage. So previously shown it was 1.793. So when you scale it, it's about showing you that patients who are diabetic have 2 times more likely to experience this. So this is just to give the readers more of an understanding that how commonly it affects the diabetic patients as compared to non-diabetic patients. And as for the odds ratio, because intraoperative awareness is so rare, the number for both of them kind of merge together and becomes 1. So odds ratio just kind of tells you about how for every patient that has diabetes that experiences how for every patient that does not that experience this intraoperative awareness, how likely is it for the rest of the cohort to experience it later on? So our idea to use it was because just to show you that how common it is in diabetic compared to non-diabetic.
Perfect. Thank you. And Dr. Davletov, if you could like guide me on this as well. So your study was basically a retrospective cohort study. Is that correct?
Yeah, totally.
Right. So in my understanding, if I'm missing on anything, so that correctly is reported by a risk ratio, exactly what you were mentioning. But my understanding is like if it does the same job if it's a case control study through an odds ratio, because in a case control study you cannot kind of elicit it to be a causation because you're using it as case controls and going back from there. But it pretty much does the same job for most purposes. So I don't know if specifically you can report an odds ratio for a prospective cohort study. I don't know if I'm aware about that.
Yeah, actually, it's a great question, and it always depends on the research question and what outcomes you are looking for. And in this case, I do believe that this odds ratio is like we can use it. It depends on the research question.
Perfect. All right. Thank you. Good job. And
Thank
I
you.
love the research topic.
Thank you.
Thank you for the excellent questions, judges, and also for the answers, Ms. Nguyen. So now we will be moving on to displaying a QR code for audience voting. And judges, please feel free to use this transition time to submit your judging response form. As for the audiences, I did want to mention very quickly that you are invited to watch this YouTube video in your favorite format. There are 2 different lives, one for the phones, which is vertical, and one for the landscape horizontal view if you are on your laptop. So just a reminder. But also, please feel free to scan this QR code on the screen to vote for your favorite presentation. Your votes, again, will help determine the awards that we will announce during today's ceremony. So please don't forget to participate. Thank you. Next, we'll be moving on to our presenter, Dr. Malik R. Hroub from Palestine, who will be presenting their original research entitled The Intersection of Rheumatology and Cardiology, Cardiac Disease and Rheumatic Disorders within Palestinian Patients between 2022 to 2024, a retrospective cohort study.
Thank you very much. Hello, everyone. My name is Malik Hroub. I am a recent medical graduate from Anschutz University in Palestine, and today I will be presenting our study titled The Intersection of Rheumatology and Cardiology, Cardiac Disease and Rheumatic Disorders within Palestinian Patients between 2022 to 2024, which is a retrospective cohort study. Next, please. When we think of rheumatic diseases, we think mostly of joints, but sometimes rheumatology begins not in the joints, but in the heart. Next, please. We all know rheumatic diseases cause pain, disability, and long-term inflammation, but what is sometimes overlooked is that this inflammation doesn't just affect the joints, it can also silently damage the heart. Globally, cardiorheumatology is gaining attention, but in Palestine we still lack data. So the question we wanted to answer in our study was, how common is cardiac involvement in rheumatology patients in our population, and what factors are associated with it? Next, please. We conducted a retrospective cohort study at Al-Maqasid Hospital from 2022 to 2024. We included 296 rheumatology patients, reviewing their electronic records, lab results, and cardiac imaging, especially echocardiography. Next, please. We analyzed demographics, rheumatology diagnostics, comorbidities, biomarkers, especially troponin and CKMB, and cardiac findings. Next, please. Key patient characteristics that we have studied included mostly women with a percent of 72 with a mean age of 49 years. The most common rheumatic diseases were as following: seronegative spondyloarthropathy accounting for approximately 25%, rheumatoid arthritis for 18%, SLE for 11%, and about 18% of our patients had clinically recognized cardiac disease. That's nearly 1 in 5. We also have observed obesity in 16.6%, smoking in 9.8%, hypertension in 30%, diabetes in 20%. Next, please. Cardiac involvement was significantly associated with older age, diabetes, hypertension, coronary artery disease, and elevated troponin and CKMB. Meanwhile, we did not find significant associations with gender, specific rheumatic diseases, or lipid profile. Next, please. So, what does this mean? Many rheumatology patients in Palestine appear to have silent cardiovascular involvement that may go unnoticed without screening. This highlights the importance of integrated cardiorheumatology care, especially in populations with chronic inflammation and relatively low smoking prevalence. And this is the first study from Palestine that examines cardiac manifestations in rheumatology patients. We found a meaningful burden of cardiac involvement and clear associations with metabolic risk factors and also cardiac biomarkers. Early screening, risk assessment, and multidisciplinary follow-up are therefore essential. Next, please. Our findings support incorporating biomarkers like troponin and CKMB and possibly routine echocardiography in the care of rheumatic patients. And we also recommend future work to develop screening protocols, study preventive therapies in high-risk patients, and conduct larger population-based studies in this region. Next, please. Now for slides 10, 11, and 12, these summarize our table of our results, and significant ones are highlighted. Next, please. Next. Next. And now, thank you very much for your listening, and I will be happy to hear your questions.
Thank you so much for your excellent presentation, Dr. Hroub. So we will now be opening the floor for questions from our judges.
Dr. Davletov, you can go first since I went twice first.
Just one question for understanding the context. Hi, Malak. Thank you. It's a really great job, and I'd like to know what is the definition of cardiac diseases in your presentation?
Cardiac disease in our population, especially, had diastolic dysfunction, but more precise data or more details were lacking from our echocardiography results, and this was because of our limitations in our region in Palestine. And therefore, from this point, we recommend for larger future research that identifies what exactly the cardiac manifestations are in these patients. But most our patients had some kind of diastolic dysfunction.
Okay, thank you.
You're welcome.
Hi, Malak. I think great job. I'd ask a simple question. In brief, could you explain me in simple terms your study design overall?
Yes, sure. Our study design is a retrospective cohort study. We have reviewed for over 2,000 patients' data from electronic records from Al-Maqasid Hospital, but we have worked at the end on 296 patients, and we have collected specific data from them, especially the rheumatologic diagnosis, the echocardiography findings, the age at diagnosis of the two conditions, and the patient characteristics like their age, their lipid profile, their comorbidities, and so on.
And what specifically was your cohort?
It was,
or the inclusion criteria?
Yes, for adults over 18 years, including both gender, female and male, and those who had all kind of rheumatological diseases.
Gotcha. So you've taken the rheumatological disease patients as the cohort and tried to assess cardiac diseases in those people.
Exactly. Yes.
And within that, we are saying all sorts of cardiac diseases, but most that you came about were diastolic heart failure patients. I think in the future would be helpful to further stratify these, because by intrinsic virtue of how diastolic heart function is as a disease, it's not necessarily one pathophysiology. It could be due to multiple different things, sometimes hard to elicit in itself, if that is necessarily due to rheumatological diseases or age-related factors. I'm sure you used appropriate tools to kind of differentiate that. Okay, thank you. Just wanted to get a good sense of that.
Thank you very much.
Thank you all for your excellent questions and answers as well. So judges, please feel free to take this transition time to submit your judging response form. We will now be displaying a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Now we'll be moving on to our next presenter, Ms. Farheen Koliatayil from India, who will be presenting her experimental study entitled Evaluation of Anxiolytic Effect of Pantoprazole on Swiss Albino Mice, an Experimental Study. Please proceed whenever you're ready.
Hi, Elaine, can you hear me?
Yes, we can hear and see you. Go ahead.
Okay, great. Hi, everybody. My name is Farheen Koliatayil. I'm from Pondicherry Institute of Medical Sciences, India. and I'll be presenting my research today on the anxiolytic effect of pantoprazole on Swiss albino mice, an experimental study. The study was done in collaboration with Dr. Shweta Uman and Jacob Abraham. So now moving on to the background of our study. Anxiety is a common human emotional state that lowers quality. It robs people of their ability to concentrate, to sleep, and live a peaceful daily existence. The current challenges that we face is that we have a worldwide prevalence of anxiety disorders at 7.3%, a lifetime prevalence as high as 33.7%, an economic cost of over $40 billion annually, and existing therapies have limited effectiveness and significant side effects. The commonly used drug classes that we see today are SSRIs, which are selective serotonin reuptake inhibitors, selective serotonin norepinephrine reuptake inhibitors, and benzodiazepines. The issues with all three drug classes are that they have partial or delayed response in many patients, a high relapse rate after stopping treatment, and the slow onset of action, especially for SSRIs and SNRIs. So I've grouped the side effects into three columns: acute effects, chronic and rare effects, and whether or not sexual dysfunction is present. So for SSRIs, headache, nausea, anxiety, insomnia are very commonly seen. More chronically, you see weight gain and bruxism, and sexual dysfunction is present at an all-time 30%. SNRIs have nausea, diarrhea, and somnolence as their acute effects, diaphoresis at high doses, tachycardia, hypertension, and discontinuation syndrome as chronic and rare effects, and venlafaxine exhibits significant sexual dysfunction. Benzodiazepines have sedation, amnesia, learning problems, and when used more often, cognitive and visuospatial deficits, dependence, and rebound anxiety. These patients on benzodiazepines usually do not complain of sexual dysfunction. Now, why pantoprazole? From the gut to the mind, an unexpected journey that we decided to explore. Proton pump inhibitors show positive effects on the nervous system. Pantoprazole delayed seizure onset, improved oxidative stress in epilepsy studies, and they also has shown to reduce neurotoxicity in human astrocytes, suggesting anti-neurotoxic properties. So this novel study evaluates pantoprazole's anxiolytic effect on Swiss albino mice. Moving on to my methodology, we chose female Swiss albino mice around 25 to 30 grams in weight, and they were divided into 5 groups, each group having 6 animals. The control group was given saline orally, standard group was given diazepam 5 mg per kg, and pantoprazole was given to the other 3 groups, 10 mg per kg, 15 mg per kg, and 20 mg per kg, all orally. The drugs were administered daily for 14 days. Behavioral assessments were done on day 1 and day 15 using the elevated plus maze and active photometer, 30 minutes post-dosing. So this is the elevated plus maze. The test is based on the natural aversion of mice for open and elevated areas, as you can see in A, as well as then on their natural spontaneous exploratory behavior in novel environments. Mice are given access to all of the arms and they're allowed to move freely between them. The time spent in the open arms are used as indices of open space-induced anxiety. The elevated plus maze relies upon rodents' proclivity towards dark and enclosed spaces that you can see in B, and an unconditioned fear of heights and open spaces. This is an active photometer, which can be used to measure the locomotor activity or horizontal activity. It operates on photoelectric cells, which are connected in a circuit with a counter. When the beam of light falling on the photo cell is cut off by the animal, a count is recorded. Reduction in the motor activity indicates CNS depressant properties of the drug, and increase in the motor activity indicates CNS stimulant properties of the drug. So these are the results of the elevated plus maze. This is the acute group. Data were analyzed using one-way ANOVA with Sheffy's post-hoc test. And as you can see in the graph, the control group, blue is for the elevated open arm, and red is elevated closed arm. The control group spend most of their time in the closed arm, as you can see the red graph, the red bar. The standard group spend most of their time in the open arm, the blue one. Dose-dependent effect can be seen through P10, P15, and P20 groups, with PAN20 group mice showing most of their time spent in the open arm. Moving on to the chronic graph, which is on day 15 of the study, P20, which is pantoprazole 20 mg per kg, shows almost a similar effect to the standard group, which is the diazepam group. Now, these are the results for the active photometer. Locomotor activity was assessed to determine the sedative effects of pantoprazole. The post-hoc analysis indicated that pantoprazole did not significantly reduce locomotor activity compared to the control, suggesting that there is no sedative effect at the tested doses. So my results are that pantoprazole at 20 milligram per kg exhibited the most patent anxiolytic effect among the treatment groups, with results closely resembling those of diazepam. The effects were dose-dependent as we saw in the graphs, and no significant sedative properties were observed at the tested doses. Moving on to my discussion, the dose-dependent effects observed in the study are consistent about what we already know of the other anxiolytic agents, such as traditional benzodiazepines. Notably, the P20 group exhibited the most pronounced anxiolytic effects across all of the tests, while P10 and P15 produced intermediate effects. This dose-response relationship suggests that pantoprazole's anxiolytic activity may involve receptor-mediated mechanisms, requiring adequate concentrations to achieve optimal effects. While its efficacy is slightly lower than that of diazepam, the lower side effects observed in the active photometer test suggest a favorable therapeutic profile. This is particularly relevant given the clinical adverse effects of currently used anxiolytic drugs, as we mentioned earlier. Potential pathways may include interactions with CNS receptors, altering processes related to apoptosis, inflammation, and oxidative stress, or effects on inflammatory mediators. Thank you. These are my references, just a few of them.
Thank you so much for your excellent presentation, Ms. Farheen. So we will now open the floor for questions from our judges.
Great job, Farheen. I think is like very interesting. Just the thought of having a PPI being used as an anti or an anxiolytic agent reminds me why we do research in the first place, I guess. Beautiful. I think my question to you would be, just because I'm not personally aware about any prior studies that have happened in this direction, are there any, or was this like a first time diving into this hypothesis? And what is other research out there outside of what you shared with us, if any?
Thank you, Dr. Singh. Actually, this is the first time it's been tested for anxiolytic effect. But there have been, like I mentioned in my slides, that there have been previous studies on epilepsy. Epilepsy and just in general, like astrotoxicity, they just checked whether it had an effect on that. So it had a positive effect on that. But in specific to anxiety, it hasn't been done before. This is the first time.
Gotcha. So there's what I see in your presentation, a few good things that kind of point things towards causation than just mere association, or the dose-response relationship that you talked about, which was great. There is some biological plausibility based on everything that you kind of described. Interesting. Thank you for sharing.
Thank you so much.
Hi, Farheen. Thank you for your presentation. I've got a question about your elevated MACE. Is it validated too?
Yes, elevated.
Wow, that's great. And one more question, please. Have you obtained did you pass the ethical committee in your university?
Yes, we do. We have to get our institutional ethical committee to sign off on this. And after that, we have CPC SCA committee as well, which has an external member, which signs off on it as well.
Excellent. And one more question, please. How did you come to this hypothesis? Is it like
I wish I had a really interesting story to tell you, but I came up with this when I was in second year, and we just started studying about PPIs, and so it wasn't like a big story that I have to it. It just came out of the blue. I just wanted to see, because as you can see, the methodology is pretty simple. The elevated plus maze and the active photometer are easily available items in like a resource limited setting. So it just fit together like pieces of a puzzle.
Okay, great job, Farheen. Thank you.
Thank you, Dr. Davletov.
Thank you so much for the excellent questions and the answers. We will now be displaying a QR code for audience voting. And judges, please feel free to take this transition time to submit your judging response form. And for the audience, please go ahead and scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Daloui. Now we'll be moving on to our next presenter, Mr. Ilya Daloui from the United States, presenting his original research entitled The Effects of Community-Based Mental Health Interventions on Resettled Adult Refugees from Muslim-Majority Countries. Unfortunately, Mr. Daloui is unable to make it in person with us today, so we will be
I am a undergraduate
starting his video instead. Okay, thank you. Go ahead.
To you guys our abstract titled The Effects of Community-Based Mental Health Interventions on Resettled Adult Refugees from Muslim-Majority Countries. This abstract was created in collaboration with my colleague Ahmad Al-Haija. Refugees from Muslim-majority countries make up one of the world's largest displaced populations, yet when they resettle in higher-income nations, they often experience significant mental health disparities. These disparities arise from overlapping causes, things like trauma from forced migration, discrimination and marginalization in host societies, and limited access to culturally sensitive mental health care. There's also limited data on how these refugees adjust psychosocially after resettlement, and as a result, most healthcare systems actually fail to address their needs in a way that respects cultural and religious contexts that are central to their identities. For many Muslim refugees, faith, cultural background, and community identity strongly shape how they interpret and seek treatment for mental illness. Stigma, which comes from both within the communities and from healthcare providers that may be unfamiliar with their cultural frameworks, often prevents individuals from pursuing care at all. The COVID-19 pandemic intensified these challenges since it brought epidemic hysteria, renewed stigmatization, and increased distrust in Western medicine, which further widened existing inequities. Community stigma, misinformation, and a lack of provider competence all contribute to poor outcomes. This highlights the need for interventions that are both community-driven and culturally informed. Our aim was to identify how community-based mental health interventions impact the unmet mental health needs of resettled Muslim refugees. We focused on understanding which approaches, whether it be faith-based, family-based, or community-based, that would be the most effective in improving psychosocial well-being and reducing mental health disparities. To this end, we conducted an integrative literature review, which allowed us to synthesize findings from both quantitative and qualitative research. This method is ideal for studying culturally diverse topics like refugee health because it integrates both statistical outcomes and lived experiences. Our inclusion criteria required that studies focus on adult refugees from Muslim-majority countries who had resettled in high-income nations. Each eligible study had to describe a specific mental health or psychosocial intervention, whether it was community, faith, or family-based, and they had to report outcomes related to mental health, things like depression, anxiety. For each study, we extracted data across 4 major categories, the first one being the environmental systems influencing mental health, such as stigma, trauma, exposure, discrimination, and healthcare access. Secondly, the actions and effects occurring across the 4 different ecological levels. Individual, which includes personal coping and therapy. Relational, which includes things like support from family, friends, and peers. Community, which includes things that are more community-based, like mosques, cultural organizations, and refugee networks. And societal, which covers broader healthcare policy. Thirdly, the reported outcomes and challenges in implementation. And lastly, the type of intervention, whether it was cultural, social, or spiritual. This structure allowed us to see both the measurable and qualitative impacts of culturally grounded care. Across the studies analyzed, many patterns emerged. The most common mental health conditions that were addressed by the interventions were depression, anxiety, PTSD, and psychological distress. These issues were almost universal across refugee groups, regardless of host country. Community-based programs that focused on social bonding and interpersonal relationships proved highly effective. For example, peer-led or family-centered interventions created safe spaces where refugees could discuss shared experiences of trauma, displacement, and trying to recover. These environments helped reduce symptoms of isolation and improved emotional resilience. Next up, faith-informed initiatives were also majorly successful. Interventions that align with Islamic principles, which again is a huge part of the identity of these Muslim refugees, such as those delivered by mosque networks or faith leaders, greatly improved participation and access outreach basically to mental health systems. They also help reduce stigma by framing mental health as something that was a spiritual growth and a collective healing. Telehealth models showed growing promise during and after COVID-19. However, they faced barriers like digital literacy and privacy concerns that limited widespread success. So these issues need to be first addressed before telehealth can be an effective system in bridging healthcare disparities. Clinician-led outreach programs highlighted more structural issues, things like lack of interpreters, insufficient cultural training, and persistent stigma within healthcare systems that proved to be damaging. Despite these barriers, the majority of interventions led to meaningful improvements. Quantitative studies showed significant reductions in depression and anxiety scores, while qualitative reports described increases in trust, social connectedness, and family cohesion. Overall, programs that emphasized social relationships, cultural familiarity, and faith alignment were most effective in improving outcomes across all 4 ecological levels. To summarize, our review found that collaborative, culturally grounded interventions enhance mental health outcomes among Muslim refugees by building trust, strengthening their identities, and reducing stigma, whether that stigma be within their communities or within the healthcare system itself. These approaches show that healing in displaced refugee populations does not happen in isolation. It is a collective process that is, pushed forward by faith, family, and community. Moving forward, we recommend conducting high-quality longitudinal studies to track outcomes over time, expanding partnerships between researchers, communities, and local faith leaders, and ensuring that telehealth systems are not just technologically functioning, but also culturally adapted to provide the care that they were meant to provide. Ultimately, this research highlights that effective refugee mental health care must be both scientific but also culturally adept to bring medicine closer to the communities that it aims to serve. Thank you for your time, and I look forward to answering your questions. Thank you.
Thank you for the presentation, Mr. Dallowee. We are sad to have missed you in person. So because he is not here with us, we will just be moving on with displaying the QR code for audience voting. And judges, please feel free to also take this transition time to submit your judging response form for Mr. Dallowee. And audience, please go ahead and scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Thank you all very much. That concludes our first session and our last session, actually, of our oral presentations. A sincere thank you to all of our presenters today for their excellent work, and to our 2 amazing judges, Dr. Davletov and also Dr. Singh, for their time and thoughtful feedback. We will now take a 10-minute coffee break. Please feel free to stretch, refresh, and return promptly. We will resume with our second session and our first poster session right after the break. Thank you. Welcome back. We will now be proceeding with our first session of poster presentations. Our first presenter is Dr. Sajjad Ahmed Khan from Nepal, who will be presenting his case report entitled Diabetic Steatopathy, a Forgotten Diagnosis in Clinical Neurology.
Okay, thank you very much. A very warm good evening to you all from Nepal. I am Dr. Sajjad Ahmed Khan, recently graduated from Virat Medical College Teaching Hospital. And I am here with you guys on this stage with a very interesting and a very unusual case of diabetic steatopathy. A very rare and a very interesting presentation, or rather complication of diabetes I'm going to talk about here. Now, before I directly enter into the case that how the patient presented in our scenario, I would like to give you a broad picture, a basic overview of what diabetic steatopathy is. What does the term steatopathy means? How does it present? And what all we know about the pathophysiology of the disease, what is the biochemical basis of diabetic steatopathy, and how we are going to diagnose the condition, and what sort of interventional modalities we have. I mean, what sort of treatment we can offer to those patients of diabetic steatopathy. Okay, so first thing first. Now talking about diabetic steatopathy is basically a acute onset chorea or hemibellismus. We all know chorea or hemibellismus is an abnormal body movement. So acute onset chorea or hemibellismus in the setting of hyperglycemia with characteristic change on neuroimaging. So there should be acute onset chorea, there should be hyperglycemia, and there should be characteristic changes on MRI. So what are those characteristic changes on MRI? Well, you can see on the top right corner of the screen, this MRI is of my patient. So you can see here, if you guys can appreciate, on the right side of the basal ganglia, there is hyperintensity noted. Note also that internal capsule is not involved. So involvement of unilateral basal ganglia, that is hyperintensity of unilateral basal ganglia, with sparing of internal capsule is very characteristic of diabetic steatopathy, a very defining neuroimaging feature of diabetic steatopathy. Now, talking about the pathophysiological process, how diabetes causes steatopathy, what is the biochemical basis? What causes hyperglycemia to present with chorea and hemibellismus? Well, the first thing is that what hyperglycemia does, hyperglycemia inhibits Krebs cycle. And we all know Krebs cycle is something which is needed to generate ATP, and body need ATP to function. So when Krebs cycle is inhibited due to hyperglycemia, body will start seeking alternate source to run TCA, alternate source to run Krebs cycle. And one of those alternate source is going to be gamma aminobutyric acid, very commonly abbreviated as GABA. So GABA is basically an inhibitory neurotransmitter. Since Krebs cycle is not operating because hyperglycemia has inhibited the Krebs cycle, now body is relying on GABA. Body is using GABA to run the Krebs cycle and to generate energy. But the problem is when GABA is utilized, there will be depletion of GABA in central nervous system. And depletion of GABA will lead to stimulatory signal, because we all know GABA is an inhibitory neurotransmitter, and lateness of inhibitory neurotransmitter in the basal ganglia will lead to disinhibition, will lead to stimulatory signal. And that's why they present with, this chorea and hemibellismus. See, we do not know the exact pathophysiology, we do not know the exact mechanism, but this is what the literature says. This is what we know so far as this steatopathy is concerned. Because steatopathy is a relatively newer term. It was in 2009 when this term was coined. Now, okay, getting back to my case. So my case is of 73-year-old male who presented with chief complaint of left leg movement, involuntary left leg movement, along with oromandibular chorea. Now, I would like to request over here, Elaine, are you there? There are two short clips in the result section. Can you please let me know if you can play them?
Okay, we're currently playing them.
Yeah, see if you can play them. Yeah, cool, nice. Can you play that video?
Okay, great. We can move. Okay, perfect.
Okay, and the second one, please.
All right, we played the two videos. You can go ahead and proceed.
Okay, so thank you very much. So I think from the video itself, it's very clear that diabetic steatopathy, how the patient presented in our case. There was acute onset movement, involuntary movement involving the left leg, and there was oromandibular chorea as well. As you guys have already seen the video, it was very much apparent from the video. So, and there was no history of any family history of such abnormal movement. There was no history of head and neck trauma. There was no history of fever. There was no history of raised intracranial tension. And there was no any neurological deficit on examination. But notably, patient was a diagnosed case of type 2 diabetes mellitus 5 years ago, and he was on metformin and glimepiride. And when we did glycemic profile, when we went ahead with this glucose workup, what we found is fasting blood glucose level was 248 and random blood sugar was 301 and glycosylated hemoglobin was 8.3. So there was a state of hyperglycemia. So we ordered a neuroimaging. We ordered an MRI. An MRI you can already see on this top right corner of the screen over here. There was a classic presentation, the very classic and defining feature of diabetic steatopathy was present here. You can see on the top right corner, just lateral to the third ventricle, you can see over here, a lateral to the internal capsule, there is hyperintensity involving the right side of basal ganglia and sparing of internal capsule. That's a very classic finding of diabetic steatopathy. So correlating clinical finding, there was a finding of chorea, there was a finding of hemivalismus, and there was hyperglycemic state, and neuroimaging finding was also in our favor. So we made a diagnosis of diabetic steatopathy. Fortunately, diabetic steatopathy is a reversible condition. All you have to do is to correct the glycemic status. So we went ahead with IV insulin, we stabilized the patient, we went ahead with this IV fluid, and once the blood sugar level was normal, we consulted endocrinologist, to take care of this glycemic profile, and for symptomatic improvement of chorea, we have given the patient clonazepam. And we have kept the patient on inpatient care for 3 days, and after 3 days he was perfectly normal. Neuroimaging has returned back to normal state, his symptoms was normal, and he was we did endocrinology consultation regarding what drug to take for diabetes, and he is doing well. On follow-up assessment, we called this patient on follow-up after 1 month, and we found that his glycemic status is under control, there is no any neuroimaging changes, and he is doing all right. So this is a story I am sharing from my neurology rotation during my clinical internship. So this is all from my side. I think we can take questions now from judges. Thank you very much.
Thank you very much, Dr. Khan. So now I'll be opening the floor for questions from our judges. Do you mind muting? Thank you. Go ahead.
Very interesting, Sajad, especially something that is of great interest to me. We kind of see a lot of strokes. And it does get complicated sometimes when strokes are not presenting typically, which is usually with some form of isolated weakness or some form of isolated cortical deficit. But it is very much possible for a stroke which is specifically affecting basal ganglia, specifically the striatum, caudate, or the putamen, to potentially present as isolated hemichorea or movement disorder, which I think makes sense in your case, right? The one thing that I would like to ask is, and you can tell me if you are aware about that as well. So on MRI, usually we do something called diffusion weighted imaging. That can a lot of times help differentiate if there is true diffusion restriction, which you see in strokes, and which I would not expect as much for a metabolic cause. Similarly, in MELAS, in pediatric strokes, because there are less true vascular strokes, but more of a metabolic happening in diabetic steatopathy. So was diffusion weighted imaging the specific MRI sequence used in this case?
Well, thank you very much, Dr. Avi. Diffusion-weighted MRI was really of great significance, particularly in this case, to rule out other cause, as you suggested. But the thing is that the center in which we were having this case was a very resource-limited setting where we do not have much availability of advanced technology. And the patient was having these symptoms for like 15 days. So when he presented to us, it was already 15 days, and we went ahead with T1 weighted image, and the sequence which is shown over there is T1 weighted MRI image. So we didn't have that specific sequence which you are interested in.
Oh, perfect. And I think the takeaway is still like knowing that you can have these rare stroke presentations, stroke being an emergency, we'll still proceed in making sure we're not having a stroke, and we can land on this diagnosis, which exists. But I think great case. Thank you for including the videos in there. very and
Exactly. Thank you. Yes, thank you, sir. That was the basic take-home message from my case that we have to differentiate this condition from a typical stroke because once we diagnose patient with stroke, we have a lot to do as far as treatment is concerned, and definitely steatopathy is something which goes on its own once you correct hyperglycemia.
And another interesting point to your notice, I usually expect a lot of metabolic disorders to be symmetrical. So you would, in my head, I would expect them to be, oh, why are both striata not involved? But actually, diabetic steatopathy is one of those which can actually more often than not present unilaterally. So it doesn't help you too much that way. Same way how hypoglycemia, even clinically can cause a lot of focal deficits. So I think
Exactly, Dr. Ravi. That was another challenging part for us because diabetes being a metabolic condition, any sort of metabolic disease will lead to disease involvement, unlike in our case, which was a typical unilateral case of steatopathy.
the only one thing that I would suggest is definitely use the term or when you're using your imaging findings, mention what specific basal ganglia is affected. Like in this case, it's the striatum, the caudate nucleus, and the putamen, because
Exactly.
though basal ganglia as a whole could be amygdala, could be subthalamus, but
Yeah, exactly. I could have been more specific in that regard. Thank you for the feedback, Dr. Ravi.
Hi, Sayat. Thank you for your presentation. It's indeed, we don't see diabetic steatopathy that often, and it's great that you raise awareness of this disease. I've got a question regarding the differential diagnosis. Did you went straight to the CT, or did you make any like electrolyte lab works? Because they also can cause these symptoms. And also, what was the reasoning of choosing MRI instead of CT? Because when we suspect stroke, we try to use CT, and it's more economically, and other questions like that. Thank you.
Thank you very much, doctor, for the question. Now, as far as the first question is concerned regarding electrolyte and metabolic panel test, so yes, we went ahead with electrolyte panel test, but all those routine investigation were normal, except for the fact that the glycemic profile was deranged, which I've already mentioned. Random blood sugar, fasting blood sugar, and glycosylated hemoglobin was elevated. So all other electrolyte panel and all other basic investigations were within normal limit. Now, coming to your second question regarding why we have chosen MRI directly and why we didn't go for a CAT scan or a CT scan. Well, we first decided to go for CT scan, but the finding in the CT scan was not very conclusive. I could have put that picture of that photo over here, but then I decided the finding was not very typical. It was very ambiguous. So just for proper confirmation, we went a step ahead to confirm those findings with MRI. And MRI finding was really something interesting and inspiring for us. I mean, to diagnose that rare entity.
Thank you for clarification, Sayat. Thank you.
Thank you very much, doctor. Thank you so much.
Thank you so much for the questions from our judges and also for the answer, Dr. Khan. So judges, go ahead and take this transition time to submit your judging response form. We will now display a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Now we will be moving on to our next presenter, Ms. Sarat Kular from India, who presents her original research entitled Association Between the Presence of Palmaris Longus Muscle and Handwriting Performance in Medical Students, a Cross-Sectional Study. Unfortunately, Ms. Kular could not be with us today, so we'll be showing her video instead. Thank you.
Hello everyone, I am Seerat Kular, third year MBBS student at IJMS Patinda. Today I would be talking about my study, that is association between the presence of palmaris longus muscle and handwriting performance in medical students, a cross-sectional study. So we would start with what is palmaris longus. Palmaris longus is a superficial muscle of the anterior compartment of forearm. What's so special about this muscle is it's absent in 1.5 to 63.9% people globally. So it is also considered functionally dispensable, which is the reason it is used in so many grafts that it does not affect any functions. But recent evidence shows that it has a role in fine motor tasks like tennis and handwriting. So in order to check the association of the presence of palmaris longus, we designed a study to compare. So the aim of the study was to determine the association, if any, between the presence of palmaris longus and handwriting performance in medical students. So we started with 200 MBBS students and we checked the presence of palmaris longus during the simple clinical test as shown in the diagram, in which the subject is asked to touch his little finger with his thumb. And if we see the prominent tendon over here in the wrist, that is the palmaris longus. We can see it is present in the left hand as shown and absent in the right hand since we cannot see any tendon. Tests. So number one is the horizontal line drawing test. A total time of 20 seconds is given to the subject, in which the person is told to draw lines from one straight vertical line to another. And as we can see that if the line crosses the boundary, then it is not considered a good line. And if it is between the two boundaries, it is considered a good line. So as we can see, the person scored 3 in this, since there was only 3 good lines. And then further we check the dot writing, which if a pinpoint dot is there, then this dot is considered. Similarly for 20 seconds, and if it extends like a worm, it is not considered a dot. So in this case, we can see that the score is 6. And third was writing of numerals, in which we didn't have any time limit. The person was asked to write the numerals from 1 to 12, and the total number of legible numbers was counted, and we could calculate the score as given. This is a validated method which checks the speed, accuracy, legibility scored using handwriting assessment battery for adults. So furthermore, descriptive statistics were computed. Associations were analyzed using regression models, negative, binomial, Poisson, and linear. We took a p-value of less than 0.005 as statistically significant. So as we can see in the results, most participants were right-handed. The palmaris longus was absent in 5.5% of the people, and it was more absent in females. As we can see that the prevalence of the right-only palmaris longus is 3.5% and left only is 2.5. We can see that the absence score was overall 5.5%. The dot writing scores and the numeral writing scores also showed no statistical significant variation with palmaris longus presence. So we can see that there was no statistical significance between palmaris longus and the scores, as we can see that there was equivalent distribution of the curves. We can see, but this is broader due to the larger number of people in the people present palmaris longus, so they have a wider distribution, but otherwise the curve shape is same in all the curves. So we did the horizontal line scores, which was lower in males, as expected that males have a bad handwriting, and it was higher in right-handed people. But it didn't show any association with the dominant hand palmaris longus. So what our studies highlight is that palmaris longus absence was similar to global trends, but there was no association between handwriting and palmaris longus presence, as it was highlighted by previous study done by this person in the last study here by Ghanem Shukri. We could clearly say that the methodology of our study was better, since we used objective measurements of handwriting instead of just classifying handwriting as good good, bad, or intermediate as done by them. So we can say that if we go on to a better methodology, we can further test the hypothesis, and in this way we could prove the hypothesis wrong, and it supports the physiological plausibility also, and it supports the argument that the Parmes longus can be safely taken for harvesting of grafts. And so we can say that objective scoring gives true picture, and it is equally important um, to report negative findings of a study, as we can see here. There's a publication bias. People tend to publish studies only if they report something positive. But our study shows that how important it is to report non-significant results, because they are important to negate the positive results as shown by the previous studies. So as we can conclude, handwriting depends on practice, coordination, and visual motor control. Then larger scale studies are needed with these objective measures to finally come to a conclusion, even in sports like tennis. Thank you so much.
Excellent presentation. Ms. Kular, we are sad to have missed you. So because she's not here with us, we will just have our judges. If you can, please feel free to take this transition time to submit your judging response form. As for the audience, we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you so much. All right, now we will be moving on to our next presenter, Ms. Marhayat Kostova. I'm so sorry if I butchered that, from Ukraine, who will be presenting her case report on the efficacy of narrowband UVB phototherapy in mild to moderate psoriasis, a case series from Kharkiv, Ukraine.
Hello, everyone. My name is Margarita Khaustova. I'm first year medical student from Kharkiv National Medical University, Ukraine. It's a great pleasure to present my research poster entitled Efficacy of Narrowband Ultraviolet B Phototherapy in Mild to Moderate Psoriasis. It's a case series from Ukraine. So generally, psoriasis is genetically determined chronic autoimmune multisystemic disease of the skin and joints with multifactorial genesis. Disease severity is generally classified due to percentage of body surface area injury and the impact on quality of life. Many factors could impact its prevalence, and currently psychological stress during military action in Ukraine could serve as a trigger, causing an increase in occurrence and severity of the disease. Unfortunately, the official statistics of disease severity are absent, but according to 2013 data, Ukraine ranked fourth worldwide in psoriasis prevalence, affecting about 3% of country's population. Due to American Psoriasis Foundation guidelines, recommend topical corticosteroid therapy as the first-line treatment for mild to moderate psoriasis, and systemic medications are recommended for moderate to severe psoriasis, while adding topical therapy as an adjuvant. Combinative approach is utilized to achieve more efficient treatment. For instance, phototherapy is an option for patients with no photosensitivity disorders and no risk of skin cancer, and narrowband ultraviolet light B phototherapy is considered as a first-line treatment. Symptomatic management could vary due to disease features. Several authors have mentioned with psoriasis. And this study aims to evaluate the efficacy of narrowband ultraviolet B phototherapy in mild to moderate psoriasis using psoriasis area and severity index and dermatologic life quality index, DLQ questionnaire assessment tools. So we conducted prospective case series, including 5 patients treated at a dermatologic center in Ukraine between February and May 2025. Inclusion criteria were age more 18 years, diagnosis of mild to moderate psoriasis, in patient treatment due to skin cancer, xeroderma pigmentosum, and pregnancy or breastfeeding were excluded from the study. All procedures were performed using solar-light lamp with narrowband ultraviolet B spectrum. Twice-weekly treatment regimen was applied with a total number of sessions ranging from 10 to 20, individualized based on treatment's response. In addition to phototherapy, patients were prescribed topical corticosteroids with antihistamines to reduce inflammation and pruritus. Their psoriasis severity was evaluated according to PASI. Primarily and at each fifth session, and the quality of life with the disease was related according to the LKE. The questionnaire was given to patients at the beginning and at the end of phototherapy treatment, and the clinical efficacy of the treatment was evaluated due to a special formula. Basic statistical analysis were performed using Microsoft Excel and additional tools for statistical calculations. The study included 5 patients, so it was 4 male and 1 male, females and 1 male, with mean age of 42 years. 4 had mild and 1 had moderate psoriasis. Their clinical types were plaque, including scalp and palmoplantar, and gutate forms. Psoriatic arthritis was the only comorbidity observed. All patients identified psychological stress as a potential trigger for the disease exacerbation. The full course of phototherapy was performed in all cases. 1 patient received 10 sessions, 3 patients received 15 sessions, and 1 patient received 20 sessions, as it showed on our tables and figures. All cases had adjuvant treatment with topical corticosteroids and antihistamines. Their reduction in severity was observed in all patients, and clinical efficacy was identified in 4 out of 5 patients, which means more that due to the formula, it was more than 75%. And only patients 4 with gutate psoriasis achieved PASI 50. A Bickle sunshine run test showed that reduction in PASI was not statistically significant. It was P 0.06, likely due to the small sample size. Nevertheless, the magnitude of improvement in the PASI results suggests a clinically relevant response. All patients reported a reduction in pruritus due to the treatment course, particularly after the 5th session, and no adverse effects were observed during or after phototherapy. Quality of life also improved in all cases. In conclusion, our case series demonstrated that narrowband ultraviolet B phototherapy, when combined with topical corticosteroids and antihistamines, demonstrated clinical improvement in most of patients with mild to moderate psoriasis, especially of the plaque type. However, given the small sample size and the presence of adjuvant treatments, these results could be interpreted with caution. And further studies, of course, are required to evaluate the independent efficacy of narrowband ultraviolet B and optimize treatment regimens. Thank you so much for your attention. I'd be happy to answer any questions if you have.
Thank you so much for your excellent presentation, Ms. Kostova. So now I'll be introducing our new judge, Dr. Tahina Fatima, a biomedical research scientist from the Health and Education for All United States. Welcome, Dr. Fatima. So please feel free to ask any questions that you have.
Hi, thanks for having me here, and great presentation, Kostova. I have a quick question. So I see that your patients also receive like topical steroids and antihistamines, right? So how do you isolate the effect of NB-UVB? Hello?
Hi, Ms. Kostova, can you hear us?
Sorry, it's a bit poor connection. Could you please repeat?
Yeah, sure. So I was saying, since patients also received topical steroids, right, and antihistamines, so how do you isolate the therapeutic effect of NB-UVB from that?
We hadn't individualized. We hadn't divided onto two treatments, so it was like combinative. And it was only indications to prevent any not successful treatment course. So antihistamines were as usual.
I can't hear.
Mostly suppressant. And
I couldn't hear some parts of it in the middle, but if we are in short of time, I can skip and go ahead with the second question.
Yeah, no, go ahead. Yeah.
Okay. So I know that this is a case series, but your sample size is 5, right? So, even though it's a case series, how do you justify the clinical significance of your findings despite like this small sample size?
We're going to give her few seconds.
Sure. Take your time.
Ms. Kostova, can you hear us? Okay, no worries. We will move on now. Thank you so much, Dr. Fatima and Ms. Kostova as well. Dr. Fatima, please feel free to use this transition time to submit your judging response form. As for the audience, we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. We will be moving on to our next presenter, Ms. Manur Ahmed from Pakistan, who will be presenting her cohort study on what medical students can learn from the 2024 dengue outbreak in Pakistan, clinical spectrum, biochemical abnormalities, and predictors of severity. Whenever you're ready.
Yeah, thank you so much. So greetings from Pakistan. I am Manur Ahmed, a final year MBBS student from Rawalpindi Medical University, Pakistan. It's an honor for me here to share my. For me to share my research with you. The topic of my study is what medical students can learn from 2024 dengue outbreak in Pakistan, clinical spectrum, biochemical abnormalities, and predictors of severity. Dengue fever has emerged as a major public health problem in tropics and subtropics. Each year, there are over 400 million cases of dengue fever worldwide and 22,000 fatalities. In 2024, there was a surge in dengue cases with about 14 million new cases that surpassed the 7 million cases of 2023, showing a twofold greater increase than 2023. And dengue fever is endemic in Pakistan since 1995, with significant outbreaks occurring regularly during and after the monsoon season. Since Pakistan is located in South Asia and it has a temperate climate, so following the flood of 2022, there were a surge in dengue cases in Pakistan, and they were primarily because of inadequate sanitation, favorable monsoon weather for mosquito breeding, and inadequate vector control measures. So dengue virus, dengue fever is caused by dengue virus, which is from the family Flavivirus, and it is vectored by Aedes aegypti and Aedes albopictus. It has 4 serotypes from then V1 to V4, and the clinical spectrum ranges from mild self-limiting feverish illness called dengue fever to life-threatening illness causing massive plasma leakage and hemorrhage called dengue hemorrhage, and circulatory failure called dengue shock syndrome. So we conducted a study to provide insights into the demographic profile, clinical manifestations, biochemical abnormalities, and outcomes of patients admitted with dengue fever during the 2024 outbreak in Pakistan. My study is a cross-sectional study conducted at Department of Medicine, Fauji Foundation Hospital, Rawalpindi from August to November 2024. The patients which were admitted with dengue virus, they were diagnosed on the basis of either a positive dengue NS1 antigen test or a positive IgM antibody or both. The patients with chronic illnesses like diabetes, hypertension, and chronic renal failure, chronic liver disease, cirrhosis of liver, they all were excluded from the study. Children actually with age of 12 less than 12 years, they were admitted in pediatrics department and they were also excluded from our study. We stratified our patients according to the WHO 2009 revised classification of dengue. Number 1 is dengue without warning signs. Number 2, dengue with warning signs. The warning signs include abdominal pain, persistent vomiting, fluid accumulation, mucosal bleed, lethargy, liver enlargement, increased hematocrit with decreased platelets. The third classification is the severe dengue group, in which patients with severe plasma leakage causing significant respiratory distress, patients with severe bleeding, patients with shock or organ dysfunction like acute kidney injury, they are included. So a total of 198 patients were enrolled in our study. 84% were from the Potohar Plateau of Punjab, including the Rawalpindi, Jhelum districts. Dengue NS1 antigen was positive in 132 patients. IgM antibody was positive in 21 patients, and both NS1 and IgM were positive in 45 patients. The mean age was 39 years. Our data actually showed a bimodal age distribution with one peak around the 20 years and the other peak around 50 years. Mean age was around 39 years, and in a study, majority like 173 patients, they were females. This female preponderance seen in our data was actually because of the catchment characteristics of Fauji Foundation Hospital, because it primarily caters the families of military personnels. The mean duration of hospital stay was 4.9 years. 4.9 days. 13% patients were characterized as dengue without warning signs. 76% patients, that is a major chunk of our patients, they were dengue with warning signs. 11% patients were patients of severe dengue. In a study, 184 patients survived while 14 patients died, making a mortality rate of around 7%. And all the 14 fatal cases, they belong to the severe dengue group. There was no statistically significant difference in age between the survivors and the non-survivors. Mortality was significantly higher among males, 24%. The odds ratio of a male dying was 10.8 as compared to that of a female. So as we can see from the graph that is attached below, fever, myalgia, and rash. This is known as the dengue triad, and these were the predominant presenting symptoms in both the survivors and the non-survivors. As we go down the graph, we can see that abdominal pain, vomiting, mucosal bleed, these were the predominant symptoms in non-survivors. And all the non-survivors, majority of the non-survivors, they had third space fluid loss. 13 of them out of 14, they had third space fluid loss. 10 were in shock. 11 had platelet counts less than 10,000. And 6 had ALT more than 500. APTT more than 2 was also present in 6 of them. And creatinine more than 2 that showed AKI was seen in 6 of them. So what does our study show? That the 2024 dengue outbreak in the Potohar region of Pakistan was characterized by high rate of severe dengue and mortality. These findings, they actually reinforce the utility of WHO 2009 classification for stratifying the patients, so that the features that are suggestive of severe dengue, they should alert the physicians for higher risk of mortality. In conclusion, Severe dengue with severe plasma leak, organ dysfunction like acute kidney injury, or coagulopathy predicted mortality, underscoring the need to use the WHO 2009 classification for timely triage and management. Thank you so much. And I'm open for any questions that you may ask.
Thank you for that excellent presentation, Ms. Manor. So I will be opening the floor for questions from our judges. I'd also like to introduce a new judge who has arrived, Dr. Sahid Mukida, the Associate Professor of Microbiology and Infectious Disease at the Dr. D.Y. Patel Medical College, Hospital and Research Center in India. So whenever you're ready, please go ahead and ask your questions. Try again, Dr. Mukida. Can you all hear him? No, not quite. Okay, sorry, Dr. Mukida. Do you mind doing the same thing as yesterday and typing? Yeah, we're unable to hear you still. While Dr. Mukida works out his audio issues, Dr. Fatima, you're welcome to ask questions.
Sure. Hi, Mahanur. Great presentation with really amazing clarity. So I have two quick questions. My first question is, did you identify predictors in your cross-sectional study?
Yes, ma'am. The predictors of you're asking about the predictors of mortality.
Yeah. So my next question is, can you walk me through the statistical process of identifying the predictors for your study?
Ma'am, the predictors that we identified in our study, there was number one, they were age, and we have seen that actually there was no statistical difference in age between the non-survivors and survivors. The other was the gender, and we have seen that male gender, they were male gender was they had a statistically significant higher rate of mortality as compared to females. Other predictors included that we actually the patients who had severe dengue, actually that is one reason is because that they had a prior dengue infection. So we have to rule out that first, but unfortunately in our hospital for G Foundation we do not have the IgG test done, so we were unable to rule out that the patients had previous dengue infection or not. And ma'am, for that and for this study, we use the chi-square test. If you're asking about the second
Yeah, that's
question.
what I was asking. So you used chi-square test to identify the predictors. Is that right?
Yes.
Okay. Okay. Thank you. And then you also mentioned that there are many severe dengue cases which were female, but we see that the mortality is higher in male, right? So from your experience,
ma'am.
how do you
Yeah.
explain this gender
So,
discrepancy?
ma'am, can you please repeat the last line?
Yeah,
I
sure.
was
So
unable to hear you.
Yeah, I'm able to hear. I was asking, so there is a gender discrepancy between the male and female, and you presented that male patients had higher mortality. So from your experience, how do you explain this gender discrepancy?
Yeah, so in our study, majority of the patients were females. Why? Because for G Foundation Hospital, it actually caters the family members of the retired military personnel. That retired military person, he is entitled in military hospital. The family members, including the wife, mother, all of them are actually entitled in our hospital, Fauji Foundation Hospital. So majority patients that come here are the family members, and therefore we had majority female preponderance in our hospital. Otherwise, worldwide they seen that male, they have in our study also they had high risk of mortality because
And
of
do
the
you think of
gender-based
any
differences in males have a higher risk of mortality.
Okay,
than
okay.
females.
I will let you answer Dr. Sajid questions first, and if I have more question and time, maybe I'll go for one more.
Okay,
Sounds
thank you
good.
so much.
In terms of Dr. Mikita's questions, because he's experiencing some audio issues, he did ask how many cases in your study have converted to dengue hemorrhagic fever?
Okay, I had these statistics here. Yeah, so in our patients, as I mentioned that 13 patients, they had third space fluid loss. 10 of them were in shock. 11 patients had platelets less than 10,000. 6 had AKI more than 500. 11 had hematocrit more than 20. 3 with acute kidney injury and 6 with APTT more than 2.
Okay, thank you. And then
These were these.
Thank you so much. And the next question that he had was, how have you managed the dengue cases? Are there any cases that required platelet transfusion? Ms. Manor, were you able to hear me? Hello, were you able to hear me?
Yeah. Yes, I am able to hear you. Sorry, can you please repeat the question?
Yeah. How have you managed the dengue cases? Are there any cases that required platelet transfusion?
Yes, ma'am, we manage the cases with fluid resuscitation and fluid resuscitation with platelet transfusions. And I don't exactly remember how many of them had platelet transfusions.
Okay, no worries. Thank you so much. Dr. Fachman, did you have any follow-up questions?
Yeah, I just wanted to understand Manu's perspective. Can you think of any biological plausibility of male patients having higher mortality for dengue severity? It's fine. It's just a perspective question. Don't worry about it.
Ms. Manor, were you able to hear us?
Ma'am, yes. This is because of the gender-based differences in immune responses of between males and females, and I think that's it.
Okay, thank you.
No worries. Thank you so much, judges, for your questions. Judges, please go ahead and take this transition time to submit your judging response form. As for the audience, we will now be displaying a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. We will be moving on to our next presenter, Dr. Dharani Dharamaj from India, who will be presenting their original research entitled Cross-Sectional Study on Air Pollution and its Influence on Health-Related Quality of Life in Coimbatore.
Yes, can I start?
Yes, please proceed. Thank you.
My study is on a cross-sectional study on indoor air pollution and its influence on health-related quality of life in Coimbatore. Myself, Dr. Dharani Dharamaj, a postgraduate from Department of Community Medicine, Karpagam Faculty of Medical Sciences and Research in India. As we all know clearly that global ecosystems and climate have a profound connection to air quality. In 2019, World Health Organization states 99% of people lived in low air quality areas, with India ranking third globally and causing 1.67 million, that is almost 17.8% death due to both indoor and outdoor air pollution. Our aim of the study is to assess indoor air pollution and its influence on health-related quality of life in an urban population. My flowchart already showing my methodology. That is, we conducted a cross-sectional study in an urban field practice area of our college, which consists of 3 areas with a population of 48,375. And as I already stated, we assume the prevalence is 99%, where already as WHO stated 99% of the people lived in low air quality areas. We assumed this prevalence is 99%, and stage 1 we have done a probability proportionate to size, and stage 2, that is systematic random sampling, was done. Every 5th house was approached and assessed for the eligibility, that is age greater than 18 years and residency, that is more than 1 year in that particular area. And if they haven't not given the consent or eligibility is not fulfilled, they were excluded from the study. And if they are fulfilled, study tools such as which is a pre-tested and pre-validated, pre-tested and semi-structured questionnaire for indoor air pollution has been applied, and EuroQOL, that is 5-dimension, 5-level, that is EQ 5D 5L was added, and EuroQOL visual analog scale EQ was also applied for the study participants. Data were collected and entered in Microsoft Excel and analyzed in an SPSS software. Descriptive statistics was done, and chi-square was done for seeing the association between the categorical variables, and survival analysis has been done. That is, Cox proportional hazard model was done for to see a hazard ratio, and Kaplan-Meier curve to visualize the life expectancy deterioration was done. As my results states, we have conducted a study in 400 participants. EQ 5D 5L score distribution among the study participants were 39.6% about perfect health, and 60.4% about poor health was seen in our study participants. And in figure 3, the figure compares the cumulative hazard of life expectancy deterioration between the individuals exposed and non-exposed to the indoor air pollution. Almost the nearly overlapping curves indicates no meaningful difference in timing of the deterioration between the two groups here. While indoor air pollution affects the symptoms, health-related quality of life into independent impact, but not on a long-term survival was not being noted here. That may be likely due to an influences from the factors such as socioeconomic factors, ventilation or comorbidities and nutrition. As add-on, table demonstrates the Cox regressions for the indoor air pollution and life expectancy deterioration here, where life expectancy deterioration hazard risk ratio was 0.91 and p-value was 0.56. Exposure to the indoor air pollution does not significantly influences the timing with the life expectancy deterioration, where p-value, as I stated, 0.56, and the probability of the life expectancy deterioration is 0.91 times higher in with the presence of indoor air pollution than with the absence of air pollution in our study. As the part of discussion, indoor air pollution significantly associated with life expectancy deterioration, but did not affect independently on the survival analysis. While its stronger impact on symptoms and health-related quality of life remains an evident in literature, which is similar to Gordon et al. In 2018 and Balakrishnan et al. In 2019. I could like to conclude my study, that is, indoor air pollution reduced health-related quality of life, that is 4.56 years quality-adjusted life expectancy loss in my study, but it did not independently affect the life expectancy, hereby recommending and future scope as a device-based exposure assessment to strengthen the causal interpretation. Thank you for the opportunity.
Thank you so much for the excellent presentation. So now we will be opening the floor to questions from our judges. Dr. Fatima, please go ahead.
Sure. Great presentation, Dr. Dharani, and I loved how you used a flowchart for the methodology. So my first question is, excuse me, this is a cross-sectional study and we know that it limits the causality. So how would you interpret the association of your exposure and your outcome?
Actually, we have done a chi-square association for all the, extra questions, that is socioeconomic status, male and female gender, and even the symptoms or a diagnosis made, such as bronchial asthma, allergic rhinitis, everything we had a association. But it is really due to indoor air pollution that was a question arise. Then we came into a concept called survival analysis, where we all know we have done survival analysis in RCT comparison parts, but here have taken as an right sensor data, and I have done as an a survival analysis here, where we could see some few changes. That is, life expectancy deterioration has been seen, but it is not completely due to air pollution. It may be due to some of the comorbidities present in the my study participants.
Right, thank you. And my next question is, what confounders did you choose while analyzing your outcomes?
Actually, we have tested for all the socioeconomic status, ventilation, proper and overcrowding, second-hand smoking, and even we have planned to assess the third-hand smoking after the device we are planning to use in a future study. And as well as we have confoundings such as comorbidities also has been assessed here, and even whether they are exposed to the road dust particles or not, and nearby air quality index, that is also assessed, in which where the air quality index of that area was satisfactory.
Okay, and why and how did you choose this confounder as one? Second is, how are you, because you use so many confounders with a limited sample size, how are you ensuring you are not overfitting the model?
Actually, we already had a number of studies that survey-based model in an indoor air pollution. But though we have a only questionnaire-based study, not on a device-based study, I really wanted to know the survival impact, because a lot of studies have been stated that 5 years loss of life expectancy due to air pollution, but not particularly due to the indoor air pollution. So I wanted to study, and I have assessed all the confounders as all the already previous stated studies has been mentioned.
Perfect. Thank you so much.
Thank you.
Thank you so much, Dr. Fatima and Dr. Dharmaraj for the excellent question and answer. So Dr. Mukita does have a question. He asks, do you know about the current status of AQI of several metro cities like Delhi? What do you suggest to improve the AQI and treat the patients affected due to air pollution?
Okay. Already, we know that air quality index is very poor in Delhi, and we are almost banning all the, diesel-related cars, and it's already in the grade third model, I think so. GRASP third model, we have been implemented in Delhi. And this may be what we can do is, what suggestion can be done is, in Brazil, all such countries, they have been monitoring the air quality index, and they are preventing, they are producing the models such as preventing from assessing the lung problems and assessing the problems from the younger age is maybe the one solution I may give for the Delhi problems. And obviously the population rate is increasing. Though we may say that urbanization, modernization, everything, but there should be a limited space area. It should be housing status, everything should be in an criteria. As per the standards, if we go, maybe.
Thank you so much. So Dr. Mukita actually did share a link, but I'm unable to just say the link. So if you may go ahead and refer to the chat for his link as well. It's under the DOI, and you can go ahead and look at that. Thank you so much, judges, and Dr. Dharmaraj for the excellent question and answer session. So judges, go ahead and feel free to take this transition time to submit your judging response form. We will now display a QR code for audience voting.
Thank you.
Thank you. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. We will be moving on to our next presenter, Mr. Sarash Gupta from India, who will be presenting his original research entitled MALAT1 and MEOT as Emerging Biomarkers for Diabetic Retinopathy, a Systematic Review and Meta-Analysis. Unfortunately, Mr. Gupta is unable to be with us in person today, so we will be presenting his video. Thank you.
Good morning, everyone. Here I am, Sarash Gupta, a pre-final MBBS student from All India Institute of Medical Sciences, Bathinda, India. Here I am to present one of my systematic reviews titled as MALAT1 and MEOT as Emerging Biomarkers for Diabetic Retinopathy, a Systematic Review and Meta-Analysis. Below are all of my following co-authors. So let's start from background. So diabetic retinopathy is a leading cause of preventable blindness, which often remains undiagnosed until advanced stages. India bears a major share of the global diabetes burden, making early diabetic retinopathy detection a public health priority. Long non-coding RNAs, including MALAT1 and MEOT, regulate inflammation, angiogenesis, and oxidative stress in DR. Their altered expression in tear fluid suggests strong potential as non-invasive diagnostic biomarkers, for which this systematic review and meta-analysis evaluates their diagnostic potential as non-invasive biomarkers for early DR detection. So in the methodology, this review followed strictly PRISMA 2020 guidelines and was registered in Prospero. A comprehensive search was conducted across PubMed, Embase, Scopus, and PubMed Central for studies assessing MALAT1 and MEOT as diagnostic biomarkers for DR. Eligible studies included original clinical or case-controlled research using tear, plasma, serum, or vitreous samples. Exclusions were in vitro, animal, review, or non-English studies, or any study lacking the diagnostic accuracy data. Data on study details included biomarker type, sample source, and diagnostic parameters, which included area under curve, sensitivity, specificity. They were systematically extracted. These metrics were analyzed to evaluate the diagnostic utility of MALAT1 and MEOT in identifying DR. So, out of the 52 identified studies, only 5 met the inclusion criteria after screening and full text review. All of the included studies were cross-sectional observational studies, mostly using serum or plasma samples from countries involving China, Canada, and Egypt. The pooled area under curve under the random effects model was 0.761 with 95% confidence interval, indicating good diagnostic accuracy, though moderate heterogeneity was observed. This can be seen in the figure 1 below. While the pooled area under curve for MALAT1 was 0.737 with moderate heterogeneity, which can be seen. While the pooled area under curve for MEOT was 0.786 with 95% confidence interval and with no significant heterogeneity, which can be seen on the right side in the figure 3. So these findings indicate MEOT as superior diagnostic performance for detecting DR, as it has a better pooled area under curve. So in the discussion, I would like to discuss actually how does the MALAT1 acts as a biomarker or helps in the pathogenesis of the DR. So the high glucose first act on the retinal pigment epithelial cells in our eyes, which leads to the increased formation of SP1 and MALAT1, which leads to the increased expression of MALAT1, which is followed by the major 4 pathogenetic models. The first one includes the inclusion of microRNAs and STAT3, which leads to the involvement of collagens and ultimately lead to fibrosis. While It also involves PRC2 and leads to inflammation. It also acts through microRNAs and leads to the increased angiogenesis, and also acts through NAP1 and leads to the increased oxidative stress. So these all helps in the pathogenesis of diabetic retinopathy. Thus, an increased levels of MELAT1 or MEAT can help us in detecting the DR. We are hypothesizing that if we are able to detect this MELAT1 and MEAT in the tear fluids, they can act as the diagnostic, like increased non-invasive diagnostic potential, for which the rapid diagnostic test can also be created. So I would like to conclude by stating that this meta-analysis supports MELAT1 and MEAT as promising non-invasive biomarkers for early detection, and their strong diagnostic accuracy and mechanistic relevance highlight the potential for future clinical integration pending validation through larger multicentric study. So below are my references. Thank you so much.
Thank you for the presentation, Mr. Gupta. We are sad to have missed you today. Since he is not here today, we will be moving on to our next presenter shortly. But first, judges, please feel free to take this transition time to submit your judging response form. As for the audiences, we will now display a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony. So please don't forget to participate. Thank you. We will be moving on to our next presenter, Dr. Aysa Silla Kumtepe from Turkey, who will be presenting their retrospective analysis or original research entitled Aging Patients, Changing Substances, Unexpected Demographic Shifts in Turkey's Drug Treatment Admissions Over a Decade.
Hello everyone, I hope every one of you is having a great day. My name is Ayça and today I will present our analysis on the unexpected demographic and epidemiological shifts observed in Turkey's substance use treatment admissions over the last decade. So to give background information, this study not only reveals changing trends in addiction, but also uncovers emerging public health risks that are becoming increasingly more important for treatment systems. Substance use disorder remains a global public health concern, and its demographic profile is changing rapidly. Aging populations, evolving social dynamics, and expanding access to psychoactive substances have reshaped who seeks treatment and why. Turkey is really key to understanding all of these because it's situated at the intersection of Europe and Asia and is uniquely influenced by these global patterns. Over the last decade, the country has experienced notable shifts in treatment-seeking patterns, substance use preferences, and mortality outcomes. Understanding these changes is essential for planning responsive and also inclusive public health strategies. As doctors, it's really important for us to have such strategies because we are the ones who see patients. And that was what our aim was when we were doing this study. It was to investigate how the demographic and clinical characteristic of our patients evolve and what kind of patients are we going to see and how are we going to help strategize a better outcome for our patients. What we did was we took our national register data from substance use treatment centers across Turkey between 2013 to 2023. We used variables included age, gender, primary substance abuse, and treatment outcomes. Descriptive and comparative analysis was conducted to identify temporal trends in demographic shifts. Let's skip to our key findings. Over our study period, treatment admissions for substance use disorder increased by 60%. This reflects both higher prevalence and also a better access to treatment programs. Direct drug-related mortality declined by almost 40%, coinciding with the implementation of harm reduction policies. this is really important because harm reduction policies are yet to become the norm for Turkey and also other less developed countries. And this really shows us that we need more of these harm reduction policies and strategies. Methamphetamine emerged as the dominant substance with an average annual prevalence increase of 46.2%. This is a really important point as well as doctors because we see methamphetamines come to play after some time and displacing opioids as the primary substance because the admissions fell from 76.3% to 42%. And this is, again, really important for us as doctors so we can understand what our patients are using and how we can approach them better. In 2022, 75.2% of drug-related deaths were linked to polydrug use, indicating increasing complexity in substance use patterns. And this is a growing public health concerns when it comes to people who use drugs and us who treat them, because now we have to use newer, better strategies for people who mixes drugs rather than one drug-related solutions. Female participation in treatment rose from 5.2% to 9.7%. And this shows us there is a narrowing gender gap between females and males. The mean age of treatment entries also increased, which shows us, again, we are now seeing a more aged population of patients. As such, educational diversity among patients also broadened, which represents a wider range of academic backgrounds. So all of these three points shows us and negates us to a different patient group than we see before. Now we're seeing a different population who are more educated, who are older, and more of them are now women. Despite progress in treatment expansion, HIV seropositivity among people who inject drugs increased 6.7-fold, predominantly linked to methamphetamine injection, raising a new public health concern. Our study also included HBV and HCV counts we couldn't include here, but now we're face to face with a different crisis, which is HIV seropositivity, because now we're seeing that people who inject drugs are much more at a higher risk than before. In conclusion, our study analysis reveals profound demographic changes and shifts in Turkey's substance use landscape over the past decade. We see rising treatment admissions and declining opioid prevalence with methamphetamine taking its place, and rapid dominance of psychoactive drugs, and highlights evolving drug-related challenges. Positive outcomes include reduced drug-related mortality and increased female engagement with treatment, suggesting partial success of harm reduction policies, and encourages us to use these strategies and improve them in the future. However, the surge on methamphetamine-related harms, polydrug mortality, and HIV incidents among people who inject drugs signal urgent areas for intervention, and this is where we should take responsibility. These findings underscore the need for adaptive, evidence-based strategies that integrate harm reduction, infectious disease prevention, and targeted support for vulnerable populations. If there are any questions, I can take them.
Thank you so much, Dr. Kumtepe. So I would like to open the floor for questions from our judges. I'm going to ask Dr. Mukita's questions first, so Dr. Fatima can collect your thoughts. So Dr. Mukita did ask, why did you not check the HBV or HCV seropositivity in the article? What is the role of economic status and drug addiction in your pre-post study?
Okay, we actually checked the HBV and HCV seropositivity. HBV seropositivity was meaningfully higher in people who inject drugs than HCV seropositivity, which was not that much of high, but we couldn't include in this poster because this was a shorter version of the whole paper. So the economic status in drug addiction in pre and post study was not included in this because our study used national data, and our national data didn't include that data. So we needed to use as reliable sources as we can in the last decade, and our data didn't include that part.
Thank you so much. Now I will open the floor up to Dr. Fatima.
Thank you so much. It was lovely hearing your presentation, Dr. Kumtepe. So my question is, how do you distinguish whether the rise of methamphetamine-related admissions truly reflects the true prevalence versus improved reporting?
Sorry, can you I couldn't hear.
So I was saying, how do you distinguish the rise of methamphetamine-related admissions that truly reflects the true prevalence versus improved reporting?
Improved reporting. This was a problem and a question for us as well when we were doing our paper, and we actually what we did was we not only took data from like the data of primary substance of use, but we also used what kind of substance was used when people were found to be dead in hospitals or outside of hospitals. We also used that data, and we compared that data to each other to be able to tell if there is a truly rise in methamphetamine use, or if it was a false positive.
Okay, thank you. And my last question is, what targeted public health strategies would you recommend to address the rising HIV seropositive participants?
I think, well, especially in the terms of HIV seropositivity, we need more and more harm reduction policies. What we see from this paper is that above all else, harm reduction policies work. And for people who have HIV, if we cannot treat them fully, if we cannot cure them, as to say, we need to better educate them to how to use the needles, or how to, we need to educate other people on how to be able to tell if the other person has HIV or such. We need to provide testing kits for people. So harm reduction strategies are essential, I think, in my opinion, and this study shows it as well.
Great, thank you so much.
Thank you
so much for the excellent question and answer panel. So judges, please feel free to take this transition time to submit your judging response form. As for the audience, we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. Thank you all very much. This concludes our first session of poster presentations. A sincere thank you to all of our poster presenters for their excellent work, as well as our judges, Dr. Fatima and Dr. Mukida, for their time and thoughtful feedback. We will now take a 30-minute lunch break. So please go ahead and relax, enjoy your meal, and return promptly. We will resume with our final poster presentation after the lunch break. Thank you. We'll see you shortly. Welcome back to our second poster session and final session of this year's conference. We hope you enjoyed your lunch break. Our first presenter will be Mr. Nicholas Leon Parra from Colombia, who will be presenting his original research entitled Risk of Recurrence of Congenital Ocular Toxoplasmosis in Children, a meta-analysis review of studies with long-term clinical follow-up.
Good morning for everybody. Today I'm going to be presenting you my project that is called Risk of Recurrence of Congenital Ocular Toxoplasmosis in Children, a meta-analysis review of studies with long-term clinical follow-up. The authors of this project are Juan David Duarte Arias, Geraldine Mesa Londoño, our tutor Jorge Enrique Gómez Marín, and me, Nicolás León Parra. As introduction, I want to talk to you about congenital toxoplasmosis, where ocular involvement remains a major concern despite advances in prenatal screening and early treatment. Evidence from a French cohort with long-term follow-up showed that nearly 1/3 of affected children developed ocular lesions, with incidence peaks around 7 and 12 years of age. These recurrences were also observed in adulthood, highlighting the persistent lifelong risk and underscoring the need for sustained ophthalmological monitoring. Ocular toxoplasmosis represents one of the leading infectious causes of posterior uveitis worldwide. The disease is characterized mainly by retinochoroiditis, often involving the macula, which can result in significant visual impairment. A distinctive feature of ocular toxoplasmosis is its recurrent nature, with episodes of reactivations that may progressively damage the retina and in severe cases lead to blindness. Although this disease is a major public health problem, there are still gaps in the evidence regarding the effect of prenatal treatment on reducing clinical relapses of congenital ocular toxoplasmosis. The available literature has focused mainly on the prevention of the mother-to-child transmission and on the initial clinical presentation. The absence of consolidated studies that integrate and compare these results quantitatively makes it difficult to establish whether prenatal management modifies the prognosis. This gap justifies conducting a meta-analysis to synthesize the existing evidence and provide more robust conclusions, with the main objective of determining the relationship between prenatal treatment and the frequency of clinical relapses of congenital ocular toxoplasmosis in children during prolonged clinical follow-up. Now for the methods, the inclusion criteria was randomized clinical trials will include prospective or retrospective cohort studies with a follow-up period longer than 2 years. Eligible population were newborns of any sex with a serologically confirmed diagnosis of toxoplasmosis. Studies were required to provide ophthalmological follow-up exceeding 2 years in children who received postnatal treatment, allowing the identification of relapses. For the comparators included children who received prenatal treatment against those who did not, with all groups having received postnatal treatment for toxoplasma gondii lasting at least 1 year. Outcomes of interest were the number of patients with retinochoroidal lesions, clinical relapses, and treatment effectiveness. Okay, the search strategy was the databases used for this process were PubMed, Web of Science, and Google Scholar. The terms employed were toxoplasmosis and congenital and toxoplasmosis and ocular. The search was refined using the filters clinical trial and randomized controlled trial. Additionally, the reference of the identified articles were scrutinized to identify other pertinent studies using the snowball technique. A standardized and previously validated Excel extraction form was used. Extracted information included database source, reference, publication year, study design, number of children receiving prenatal treatment, number without prenatal treatment, definition of relapse, number of relapses in each group, and a median follow-up time in years. Okay, for the data synthesis and statistical analysis, for the quantitative integration and evaluation of the studies included in the meta-analysis, An advanced statistical analysis was performed using epidemiological synthesis tools and heterogeneity tests. Data obtained from each study were systemized into a standardized database, allowing for the calculation of association and effect measures between prenatal treatment for congenital toxoplasmosis and the risk of ocular recurrence during childhood. The statistical analysis was performed using Open Meta-Analysis software, which allowed for the generation of pooled measures and the construction of graphical representations. To explore the potential presence of publication bias, a funnel plot was generated, and additionally, a forest plot was constructed to graphically represent the relative risk estimates from each study and overall pool effect size. The relative risk served as the primary outcome measure, quantifying the association between prenatal treatment and the likelihood of ocular recurrence among children with confirmed congenital toxoplasmosis. Okay, now for the results. A total of 101 articles were identified across 3 databases. 8 were 21 in PubMed, 51 in Google Scholar, and 29 in Web of Science. During the initial screening phase, 14 studies were excluded, including 12 removed based on the title review and 2 due to unavailable abstracts. No duplicate records were identified. Subsequently, 87 articles were screened and based on titles and abstracts, of which 24 were excluded for not meeting the predefined inclusion criteria, primarily because they were descriptive studies without control group or lacked variables related to ocular recurrence for prenatal treatment. A total of 13 full-text articles were assessed for eligibility and 10 were excluded due to absence of quantitative data allowing the calculation of association measures such as relative risk or odds ratio. Ultimately, 3 studies met the methodological and quality criteria and were included in the systematic review and quantitative meta-analysis. This is all explained in Figure 1. The adjusted recurrence rate in prenatally treated children was 2.6, a total of 229, whereas in untreated children it was 16.2. And the overall adjusted risk of recurrence in prenatally treated children was 0.23 with a confidence interval of 95% and a p-value of 0.001. Okay, as you can see in this figure 2, we are comparing the percentage of new ocular episodes of toxoplasmic retinochoroiditis. So in the first study, you can see the percentage in the treated children. It was 4.16%, while in the untreated group of children, it was 66.6%. Then in the second study, the percentage of the treated children was 4.16%, while in the untreated children it was 16.6%. And finally, in the last study, the percentage in the treated children was 8.3%, while in the untreated children it was 20.8%. And in this figure 3, we did a forest plot where we calculated the difference of risk of ocular recurrences in prenatally treated children compared with those without prenatal treatment. As you can see here, the relative risk was 0.23, as I was telling you, and the p-value was 0.001. It means that this is statistically significant. Okay, now for the discussion and conclusion, only 3 studies describing ocular recurrences in congenital toxoplasmosis were found. All 3 studies demonstrated that effectiveness of prenatal treatment in reducing the frequency of these lesions during the first years of life. However, none of the studies found reported an adjusted risk for each patient in their follow-up period. It is therefore essential to describe and standardize an adjusted recurrence rate, as the risk of recurrence can vary significantly between patients.
So we'll be opening the floor up for questions from our judges. And I would also like to introduce a new judge who was able to make it, Dr. Zarmina Eshtasham, who is a molecular pathologist from Pakistan. Welcome, Dr. Eshtasham. So whenever you're ready.
Thank you so much for introducing me, and it's a pleasure to be a part of this presentation. Nicholas did a great job, and the presentation was great, the poster was great, and if you allow me to, so I'll ask you questions. I'll ask Nicholas some questions.
Yes, of course. Please proceed.
Okay, so I wanted to ask you that how did you assess the risk of bias in your studies?
Okay, so for the risk of bias, we actually calculated a funnel plot, and we also use Google Scholar for reducing this risk of bias. But there's still some risk present, and we declare it, we talk about in our full presentation, and it is because these specialized centers received only patients who are chronically affected or gravely affected. So there's a risk there. Could be a bias that we are declaring in our full presentation. But for the other, like publication bias, we did a funnel plot, and we also use Google Scholar for controlling this.
Okay. One more question I wanted to ask you is that what is the most important clinical implication in your findings, which you believe that is most important for your study?
Okay, the most important finding here, I think, is like the way the parasite can vary and it can affect the eye. It can go from inflammation of the eye, and it can lead the patient to lose his sight. It can lead to blindness. So the prenatal treatment is fundamental because it can control this infection, this eye infection, and can help to reduce these ocular relapses.
So is it going to affect any nerve?
Sorry, can you repeat? Sorry.
Is it going to affect any nerve?
I'm sorry, I don't understand.
What do you think?
Hi, Doctor. Yes, we can hear you, Dr. Eshtasham. For your last question, did you mention, like, is it going to affect any nerve? Is that correct?
Yes.
Okay. Mr. Park?
Okay. It could affect a nerve. I don't know if there is any case reporting that affection, but we have to be clear that the parasite, the infection type of the parasite, is the retina in the eye. So this is a really nerve part of the eye of the so it can really affect the nerve, and also by its closeness, it can affect the ocular nerve if the parasite infects this zone site.
Great. Thank you so much. Thank you so much for your good answers.
Thank you so much. So I will now be moving on to Dr. Fatima.
Thank you so much. Great presentation, Nicholas. So my question is, only 3 studies met your prefix criteria. So how does this limited evidence-based base affect your confidence pool in the recurrence estimation?
Okay, so I think that our first important finding here is that you mentioned, that only 3 studies reported the information we were looking for, these ocular relapses, these ocular clinical follow-up. So here is a really important finding, at first. And also, these 3 studies were big patient cohorts that reported a really long-term follow-up. They reported clinical relapses, they reported treatment, administration. They were like really the data in those studies were a really quality data. So it allowed us to do this analysis and this calculation because these three studies had really big three cohorts of patients and a really long-term clinical follow-up.
Okay, and what biological plausibilities or mechanism you can think of that might explain the protective effect of the prenatal treatment despite extensive postnatal therapy?
Okay, there are studies that report that giving prenatal treatment earlier in the pregnancy period is more effective to reduce these ocular lesions and these ocular relapses. For example, if you have a patient with, I don't know, 28 weeks of pregnancy, and you have not given her prenatal treatment, the baby is more probably to have more clinical sequels, not only ocular lesions, but also neurological lesions, neurological problems. So it's better to give this treatment in the first weeks of pregnancy.
Yeah, no, I was asking like what biological plausibilities you can think of for explaining this, prenatal treatment is better or it's affecting better than extensive postnatal therapy.
Okay. I think the biological process here could be the parasite charge. Maybe an early treatment can reduce this parasite charge so the parasite won't spread around the important organs, around the eye, the brain, so it can reduce this risk.
All right. Thank you.
Thank you for your
Thank
question.
you so much for the questions and the answers. So finally, with Dr. Mukita, I will be asking his question. So Dr. Mukita does ask, is there any other congenital infection that you can describe in reference studies? Can they interfere in the differentiation of toxoplasmosis from them?
Yes, totally. A co-infection can interfere here in our results. So one of the exclusion criteria, I didn't mention, but there's in our project, one of the exclusion criteria were studies that had or reported co-infections with other parasites, bacteria, any other microorganism. So yeah, it's pretty important to difference and to isolate just toxoplasma for our study and for this analysis.
Perfect. Thank you so much, Mr. Para, for your amazing answers. And also thank you, judges, for your questions. Judges, please go ahead and take this transition time to submit your judging response form. As for the audience, we will now display a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. And now we will be moving on to our next presenter, Mr. Martin Ho from Ireland, who will be presenting his original research entitled Near-Peer Teaching of Surgical Skills Among Medical Students, a Feasibility Study.
Hello, good evening, everyone. Can you hear me okay?
Yes, go ahead and please proceed.
Oh, very good. Good evening, everyone. Martin is my name. I'm a junior doctor working in Cork, Ireland. Today I'll be presenting my project entitled Near-Peer Teaching of Surgical Skills Among Medical Students, a Feasibility Study. Next slide, please. So laparoscopic surgery has become more prevalent across our units and has an increased unique skill set required compared with open surgery. Next transition, please. For younger students and trainees, early exposure to basic surgical skills is key to get ahead. And next slide again. However, unfortunately, many undergraduate students receive minimal hands-on surgical training. So to address this, a near-peer teaching model has been adopted. That is, senior medical students teach junior medical students surgical skills. Can we go on to the next slide, please? Previous literature on this topic generally consists of 1 to 2 day suturing courses for medical students with some subjective feedback and confidence reports. Only one study, as you can see on the bottom left, evaluated objective benefit of near-peer teaching with a control group. However, that study only really looked at suturing courses and didn't evaluate laparoscopic skills. Next slide, please. So some questions remain. How do we objectively measure laparoscopic performance? Do we want to measure how fast our participants are? How confident they are? Probably we need some more objective evaluation. Next, how long do we assess improvement? Anyone can demonstrate some improvement after 1 day, but can people show sustained improvement and retention of skill over a sustained period of time? Because that's the key marker of an efficacy of an intervention. And finally, laparoscopic skills have never been measured among medical students. Next slide, please. So we designed a prospective randomized study with the following aims: to develop a novel objective assessment tool via modified Delphi method, to assess changes in student confidence and objective performance in laparoscopic skills following peer taught and self-taught teaching, and also to identify factors associated with performance. Next slide, please. Our methods of assessment were pre-post intervention questionnaire to assess participant confidence, and also pre-post intervention recorded video assessment to assess objective performance. Next slide, please. Participants were randomized. We conducted this this study in our University College Cork Assert Stimulation Centre with 42 participants. We assessed them across 4 laparoscopic tasks, as you can see on the right: ball transfer, circle cutting, peg transfer, and string. Each participant completed 6 30-minute sessions across 6 weeks, so a total of 3 hours of training altogether. Next slide, please. Participants were randomized to group 1 and 2. Every participant received a standardized video presentation. However, only group 1, the intervention group, received near-peer teaching. In terms of our near-peer teachers, we had 6 near-peer teachers, and we had some criteria for these teachers. For example, they had to have had some previous teaching experience with the University Surgical Society. They had to have completed a formal surgical skills course, such as the Basic Surgical Skills course, and had to have some formal teaching training. Next slide, please. To evaluate our objective assessment of our videos, we used a modified Delphi method to create this novel tool. This questionnaire was developed initially with a draft questionnaire developed by the author based upon a literature review, and then several rounds of expert review following unanimous consensus. Next slide, please. Here is an evaluation sheet for one of our stations, and it's a little bit small, but you can see that this is the ball transfer station. There's points allocated for each specific task anchor and the quality performance of each step. So, for example, do they pick up the ball smoothly? Do they transfer it smoothly? Or, for example, do they transfer it slowly or fail to transfer? Do they line the ball up to the goal, and do they let it go smoothly? Additionally, there's some deduction points. For example, if they drop a ball, there's also some bonus points, and some stations allowed for a few points for overall evaluation impression. Each video was evaluated by 2 junior surgical trainees. Next slide, please. Here is a video of one of our colleagues demonstrating the peg transfer station. We had approximately 10 laparoscopic boxes available to us, so we would line them up around the classroom, and we could train 10 students at a time. We would video record each participant's recording and anonymize them and send them to a secure USB for analysis. Next slide, please. In terms of results, the mean age of our participants was 23 years old, generally more female than male students in the younger years of medical school, and most students had some previous video game exposure rather. Next slide, please. We compared the groups pre-intervention to establish baseline parity. We were able to establish baseline parity between the groups for 3 of the 4 stations. However, Group 1 did outperform Group 2 in the PEG transfer station, which was likely due to statistical chance. Next slide, please. The main aim of our study was to assess improvement in scores. Now, participants improved in all tasks across all stations, regardless of whether they are from Group 1 or Group 2. However, Group 1, the group who received near-peer teaching, they improved more than Group 2 in the circle cutting and string station, as you can see here. Next slide, please. Here's graphical representation of the same. So as you can see on the right, Group 1 outperformed Group 2 in the circle cutting and string station. Next slide, please. In terms of factor analysis, no factors, including patient age, gender, or previous video game exposure, were not associated with objective performance. Similarly, participant confidence was not associated with objective performance. Next slide, please. In terms of discussion, we are the first study to comprehensively evaluate and demonstrate a positive benefit of near-peer teaching of laparoscopic surgical skills among medical students, thus supporting its inclusion in undergraduate surgical curricula. Next slide, please. I don't have much time to discuss this, but this is the concept that underpins near-peer surgical teaching. If you're cognitively and socially closer to the people who's teaching you, then you're more likely to feel relaxed, which is conducive to learning. Next slide, please. Regarding advantages of near-peer teaching, several advantages. It is low cost. It addresses the limitations of limited, busy surgical faculty. It offers a low-pressure learning environment, increased opportunities for learning. It is student-led, so allows for opportunities for students to develop their leadership skills. It strengthens the teaching culture within the department and also within students, which they'll carry throughout their training. Some things you want to be careful of. You want to avoid teaching students bad habits and ensure consistency between teachers. Next slide, please. Some limitations associated with our study include a limited sample size and single-center design. There's also limited ability to make firm conclusions as this is a feasibility study. Next slide, please. However, we did have several strengths, including randomized design with inclusion of a control group. We included 2 blinded evaluators with good intra-class correlation coefficient, and we had a good retention rate throughout the 6 weeks. Next slide, please. In terms of future directions, we aim to conduct a multi-center randomized controlled trial powered using the effect sizes generated from this study, and also to validate our novel objective assessment tool. Next slide. Thank you very much for listening to me, and I'm happy to answer any questions.
Thank you for your presentation, Mr. Ho. So now I will be opening the floor for questions from our judges. I will start with Dr. Mukita's question so we can have the other 2 judges collect their thoughts. So Dr. Mukita asked, do you have a skill lab type setup for teaching students?
Yes. So generally in our university, the teaching of surgical skills is very limited. So it is generally a student-led initiative by a student surgical society that raises funds to buy suturing equipment or laparoscopic boxes, and students generally teach themselves surgical skills. In terms of official teaching, there are some postgraduate facilities available that teach laparoscopic surgery to trainees, but this is generally not available to students. Students essentially teach themselves surgical skills.
Thank you very much, and I'll open up the floor to Dr. Fatima or Dr. Estesham for questions.
Okay. Yeah, Dr. Estesham, you can go ahead first.
Okay, thank you so much. The presentation was nice again, and this was my second one, so it was great. My question from you is, how did you measure subjective confidence, and how did you ensure the tool was reliable?
So we measured confidence using a essentially 0 to 100 scale score. This was measured pre-intervention and post-intervention. In terms of reliability, this has content reliability. It has some construct reliability rather, because it's the same scale that's used in the previous studies that also assess participants' subjective confidence before and after.
Okay, so did you notice any significant difference in learning curves between the pre-taught and self-taught groups?
In terms of learning curves, we only measured our outcomes at baseline and at 6 weeks. In terms between the difference between baseline and 6 weeks, both groups improved objectively in all stations. Both groups became more confident in their surgical skills within those times. Due to the feasibility and limited resources and limited availability of evaluators, we didn't conduct a mid-intervention assessment such as at 3 weeks, but that would be very good to establish a learning curve or a consistent pattern rather.
Okay, and the last question would be, what objective metrics did you use for the performance regarding the economy of motion and time, etc.?
Yeah. So one of my slides has an de-evaluation sheet we used for one of our stations. Essentially, each of the 4 tasks has specific steps. So, for example, the ball transfer station, you have to pick up a ball, transfer it between the 2 graspers, and drop it down into one of the goals. So we measured the quality of performance and whether participants performed each step using essentially a tick box yes or no system, which gave students 1, 2, 3 points, for example. In addition to completing the steps, there was points allocated for performance. There was, say, for example, 5 points allocated for an overall evaluation impression, but most of the points were very objective. So, for example, if they dropped the ball, they would lose 1 point each time. If they dropped no balls, they would gain points. And each station had something unique like that. And each questionnaire was developed, again, as I said, through modified Delphi method with 3 experts in laparoscopic and surgical education.
Okay, thank you so much. Good. And Dr. Fatma, you can proceed.
Thank you. Great presentation, Dr. Ho. I absolutely enjoyed the whole presentation, and it was very helpful to see kind of the rubric of your objective assessment. So my question is, how does your novel assessment tool differ from the existing validated laparoscopic scoring systems?
Thanks for your question. Before conducting our project, we did a literature review to find any objective evaluation measures, and we actually didn't find too many. Most previous studies only looked at subjectivity, so whether students felt more confident. There was no measure of objective evaluation, and in terms of the extensive literature search we did, the measures we found were 1, time performance, so how long did it take to complete the task, and that's a very, we don't think that that's a good way to measure how well students are performing in terms of how fast they are, because we should prioritize skill rather than speed. Another method of assessment was the OSATs, which is commonly used, Objective Structured Assessment Tool. However, this assessment tool is not really applicable to laparoscopic tasks because it's, number 1, very subjective, and number 2, it includes a lot of questions such as, does the trainee make use of their assistants? Does the trainee make use of the different surgical equipment that's available to them? And these questions aren't really applicable to what we want to examine. So that's why we developed a novel tool.
Okay, great. And in your future direction, you have mentioned that you need to validate this tool. So how do you plan to conduct a validation study for this novel tool? And can you just quickly walk me through any plan if you have, like the study design?
Yeah. So there's several plans we have to, validate this. I suppose there's content validity, which we are happy that it is established because it has been evaluated by 3 laparoscopic experts. In terms of construct validity and comparing it to existing assessments, we would like to compare with the existing OSATs objective evaluation tool, the OSATs, which I just mentioned, even though we don't think it's that good, but we would still like to compare. So in a future study, we would use both questionnaires, use both the new one which we developed and also the existing OSATs, and to see is there a good correlation between participants scoring between the 2 scales.
All right, great. Thank you so much. I have no more question and good luck.
Thank you very much.
Thank you very much to our judges, and thank you, Mr. Ho, for the presentation and also the answers. So now, judges, please take this transition time to submit your judging response form, and we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. And now we will be moving on to our next presenter, Ms. Egzi Muhurcu from Turkey, who presents her original research entitled Health Anxiety Among Clinical Medical Students, a cross-sectional study at Uludağ University Faculty of Medicine.
Hello.
Hi.
Can you see me and hear me?
Yes, we can see and hear you. Please proceed.
Hello, everyone. I'm Ezgi Muhurcu, a 6th-year medical student at Uludağ University from Turkey. It's a great pleasure for me to present our research on a topic deeply relevant to our educational environment. This project was a major collaborative effort, and I must express my sincere gratitude to my professor, Professor Levent Özdemir. He is the head of the Public Health Department, and my fellow researcher, Dr. Oğuzhan Çalışkan. Their guidance and contributions were invaluable to this work. Our study investigated the health anxiety levels among clinical students at our faculty across the 4th, 5th, and the 6th academic years. We aim to identify trends and potential factors influencing anxiety as students progress through their clinical training. Today, I will cover our background, the specific aim of the study, our methodology, the main findings, and the critical implication for medical education. Health anxiety, as first defined by Salkowski and Warwick, is significant concern. It's characterized by the persistent worry about having or developing a serious illness due to the misinterpretation of normal bodily sensations. It's formally characterized as illness anxiety disorder in the DSM-5. This worry is especially relevant in our field because medical education is inherently stressful. In Turkey, medical students report higher rates of anxiety and depression compared to their non-medical peers. This is fueled by intense academic pressure, prolonged training demands, and constant emotional exposure to illness. Crucially, this heightened awareness of disease pathology can manifest in a unique way. It's called medical student syndrome. Medical student syndrome refers to a student's tendency to misinterpret benign bodily sensations as symptoms of the serious diseases they are currently studying. While typically transient, this phenomenon reflects a situational form of health anxiety, often resembling hypochondriacal traits without meeting a clinical diagnostic threshold. The distinction is important. Medical student syndrome is a cognitive bias linked to the educational context, not necessarily a psychiatric condition. Understanding this context is vital, and it led directly to our study. We aim to evaluate and specifically compare health anxiety levels across the clinical years, which includes 4th, 5th, and the 6th grades, to see how this pressure changes as training progresses. We used a cross-sectional design and collected our data via 2-part online survey from 288 participants. This sample size was calculated using concurrence formula to ensure our results were statistically representative of the clinical student population. The survey included two components. First, collecting essential sociodemographic data, and second, utilizing the validated Turkish version of the Short Health Anxiety Inventory. It's abbreviated as SHAI. The first 14 items use a 4-point Likert scale to evaluate current mental states, focusing on health-related worries and bodily vigilance. This measures present symptoms. And the last 4 hypothetical items assess the anticipated emotional responses to serious illness scenarios, providing insight into catastrophic thinking patterns. This captures vulnerability to distress. This dual structure allowed us to capture both present health anxiety symptoms and underlying illness related to distress. Our results reveal several important findings regarding the prevalence and distribution of health anxiety among our students. The overall mean SHI score was 19.2 plus minus 9.3. We found a significant difference based on gender. Female students exhibited significantly higher health anxiety than their male counterparts. The manifestation of medical student syndrome were highly prevalent. 64.2% reported experiencing distress or anxiety about having illnesses learned during their training. 54.2%, over half of our sample, consulted a physician due to a self-suspected diagnosis. As expected, students reporting this type of anxiety had significantly higher total SHI scores. Regarding the academic progression, we found no significant differences in SHI scores when comparing the 4th, 5th, and the 6th academic years. Although scores trended slightly lower in the 6th year, this difference wasn't statistically significant. Interestingly, among the students who sought medical consultation, finding out that their self-suspected diagnosis wasn't confirmed didn't significantly alter their overall anxiety levels. Having reviewed our results, I will now move on to discussion. Our overall SHI mean confirms health anxiety prevalence and aligns with international medical students data, but gender and medical student syndrome remain strong predictive factors. The high rate of self-diagnosis requiring physician consultation signals potential overutilization of institutional healthcare resources. And targeted psychoeducational intervention should be considered a critical component of the clinical curriculum. In conclusion, health anxiety is clearly prevalent among our clinical medical students, particularly females and those who exhibit the classical signs of medical student syndrome. The lack of a significant decrease in anxiety across the senior years suggests that simply acquiring clinical knowledge and experience may not be enough to fully mitigate these intense health concerns. The exposure to disease seemed to maintain, or at least not significantly reduce, the anxiety levels. These findings underscore a critical need for our institution to implement targeted interventions throughout clinical training. These could include psychoeducation sessions, cognitive reframing techniques to address catastrophic thinking, and stronger, more accessible institutional mental health support. Addressing this anxiety is vital for students' well-being and their future professional performance. Thank you very much for your time and attention. I'm now happy to take any questions.
Thank you for your excellent presentation, Ms. Mukherjee. So I am pleased to announce the judges of our next round. Professor Asmita Nimi, who is the professor of pathophysiology at the Medical University of the Americas in the West Indies. And our second judge, Dr. Samuel Dyer, MD, PhD, and CEO and chairman of the Medical Science Liaison Society. We are pleased to have both judges here. Thank you so much for your time. And we will now open the floor for questions from our judges.
Can I go first?
Good day.
Yeah. It was an excellent presentation and very important topic that you have discussed. You mentioned that there is a significant difference between females and males reporting such anxiety-related symptoms.
Yes, we found a significant. Yeah, we
Yeah.
found significant. Mhm.
Yes. So, is it that they are self-reporting more, or there is a difference in the diagnosis itself? Is it
Uh,
that females are self-reporting more than males, or it is just that the diagnosis itself is more in females than in males?
I can say that it's one of our limitations because these surveys they are subjectives. So, yeah.
Okay. And are there any further institutional measures being planned to tackle these issue?
I couldn't really get the questions. I'm sorry.
You said there is need for institutional intervention
Yeah.
to avoid these circumstances. So, what could be the future plans you can think of?
We can we offer psychoeducational they can consult a psychotherapist, or we thought that I couldn't remember its English right now.
It's fine. Don't stress yourself.
Thank you so much for the questions, Dr. Nini and Dr. Dyer.
We suggest that it should be institutions be more aware of these problems, and they should get some psychiatric consultation about this, I think, the students.
Thank you so much. Dr. Nini, is that satisfactory, or do you have any follow-up questions?
Yeah. Thank you for your answers.
Okay, awesome. Dr. Dyer, are you able to speak?
Yeah, can you hear me okay?
Yes.
Perfect. I was just doing an audio check. So thank you very much. Great presentation. It's an interesting topic, and certainly we think about medical student syndrome, as we like to classify it. It's been around for a while. And I'm curious, from your perspective, was there anything specific, any new insight from your patient population, do you think, or the population of your study rather, that makes the findings, I don't know, different or more actionable than previous research? So why'd you do this, and what was unique, any unique findings from this?
Actually, we didn't really find many articles about this, and with this SHI scores. The main thing was this SHI score. And when we compared the other results from the other articles, some of them didn't found a significant difference in genders, but we found. And also at the other articles, they were examined all the clinical years, and they generally found the second year students with more significant difference. But when we compared the clinical years, they don't really have a significant difference, but they are always have high health anxiety levels.
Yeah. And I guess just a follow-up, since, female gender, you identified female gender as a significant predictor of health anxiety. I guess the question becomes then, what do you predict? How might future interventions be adjusted or tailored based on gender specific psychological and or educational needs? What do you think about that?
Can I get the question again, please?
Yeah, absolutely. And no problem. And I'll rephrase it a little different. You had mentioned that female gender was that you identified as a significant predictor in your study of anxiety or health anxiety. I guess my question is, if that is true and thinking about that in that context, how would you expect future interventions be tailored or adjusted based on that, based on gender specific psychological or educational needs? You could guess. Yeah.
If you think about in medical, I think the medical students start to get more female students, and the doctors become more female. And I think it will, if it's continue like this with the higher anxiety levels in females, it will be more specific. It will be more important point because it means these anxiety levels, it will affect their performances. So we should be more careful about this.
Okay. Yeah, good. Thank you.
You're welcome.
And Dr. Estesham, did you have any questions for our presenter as well?
Okay, thank you so much for the presentation. It was good, and the questions were asked already by other presenters as well. I want to ask you that you mentioned that Turkish medical students show elevated anxiety and depression. What factors are unique to Turkish medical education system specifically that might contribute to this?
As I mentioned at first, the medical education is inherently stressful. It's like this all around the world, and it can be the pressure and the
Okay, it's fine. You can answer what specific interventions you already mentioned about psychoeducation, but what specific intervention would you propose for medical schools, in your opinion?
We suggest the consultation to psychiatrists actually.
Any other activity which you can propose so that it's fun also and people will contribute to it? It's fine. It's fine. Okay. Thank you.
You're welcome.
Thank you so much, judges and Ms. Mukherjee, for the wonderful presentation and question and answer panel. So judges, please take this transition time to go ahead and submit your judging response form. And for the audience, we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. And now we will be moving on to our next presenter, Dr. Wilson Penafiel-Pallares from Ecuador, who will be presenting his case report entitled Reconstruction of a Large Lumbar Carcinoma Defect using a Subtype 3 Keystone Flap Case Report. Welcome, Dr. Penafiel-Pallares.
Today I'll be presenting a challenging case of a large lumbar carcinoma reconstructed using a subtype 3 keystone perforator flap. As a quick background, large lumbar defects after oncologic resection are particularly difficult to reconstruct. This is because this region has a limited local tissue and traditional techniques like raft, free flaps, or rotational flaps often involve longer operative times and higher morbidity. The keystone perforator island flap is a faciocutaneous flap that preserves very well perforator arteries. This allows us to make a tension-free tissue advancement. Subtype 3, which uses two opposing flaps, is especially useful for midline dorsal defects. The aim of this case was to demonstrate how the subtype 3 keystone flap can successfully reconstruct a very large lumbar carcinoma defect. Now, speaking of our case, our patient was a 66-year-old female with a 2-year history of a progressively enlarging, painful lumbar mass. The mass was exophytic, irregular, and produced malodor. You can see the mass in figure section A. We performed a wide oncologic excision, obtaining a 22 by 16 centimeters defect, as you can see in figure section C. To close it, we designed a subtype 3 keystone flap using bilateral trapezoidal faciocutaneous flaps advanced in a BY fashion. This you can see in figure B. No preoperative Doppler was required. Closure was achieved without tension and 2 suction drains were placed. Finally, we had our results. In figure D, you can see that the patient had an excellent flap perfusion with no complications. She was discharged home on postoperative day 3. Histopathology revealed a poorly differentiated adenocarcinoma with lymphovascular invasion, but importantly, with negative margins. At 6 months follow-up, the wound was fully healed with no recurrence and no functional or aesthetic limitation. This case demonstrates that the keystone flap is not only a simple and safe option, but also a cost-effective alternative to microsurgical reconstruction, particularly in low-resource settings. The subtype 3 allows surgeons to close very wide dorsal defects with excellent outcomes and minimal donor site morbidity. Finally, we would like to close this quick presentation with a quick summary. As you can see in the presentation, the subtype 3 keystone flap is a very versatile, reliable, and elegant solution for reconstructing large lumbar defects. It offers functional, aesthetic, and time-efficient results without the need of microsurgery. Thank you very much for your attention.
Thank you for that excellent presentation, Dr. Penafiel.
I don't know if you can hear me now.
Yes, we can hear you now. Perfect.
Sorry,
Okay, no worries, no worries. So if we can open the floor up for questions from our judges as well. Welcome, judges. So feel free to, whoever would like to start first.
Maybe I'll just jump in. I don't know what the order is, but great presentation. And look, the audio and AV portion of all of these is the most stressful part. I'm telling you, I live it myself. So you're fine now. I'm thinking about as I went through the abstract and went through your study, I was curious, was there any long-term follow-up beyond the 6 months to evaluate or assess recurrence or even delayed complications, and what considerations might, I guess, that mean for broader adoption of this approach?
Okay, well, hi everyone. Again, sorry for the troubles for the audio.
No problem.
I'm happy to take any question. That's a really good question because we recently saw the patient. We did a 6 months follow-up and then we did a 12 months follow-up, and I think we did recently like a year and a half follow-up. The patient currently is doing great with no recurrence. We were most concerned about the
metastasis of these conditions, because we found a little bit of lymphovascular infiltration. Thinking about that, we performed a PET scan. The patient was able to perform a PET scan. It was negative. So far, apart from the aesthetic function, the patient has not mentioned any kind of symptoms that worries us about probably metastasis or recurrence of the infection. And aesthetic-wise, the lesion is perfect. Currently, we don't have any pictures to show, but we are trying to get those pictures to maybe publish the report in the future with more, like you said yourself, more long follow-up. But right now, she's doing really great.
Excellent. Thank you.
Dr. Nini or Dr. Estisham, feel free to jump in.
Okay, thank you so much for the presentation. It was good. Let's assume the patient has compromised vascularity. So would you suggest this technique or flap in that patient?
Well, speaking from the perspective of a plastic reconstructive department, first of all, it is responsible for our part to know our capacities and our limitations. We will like, before suggesting any kind of treatment, know what the other important departments are thinking too, like the oncology department, the surgical unit, or even the general surgery unit. As long as our patient, the lymphovascular complication was limited to not too much tissue, so we were able to dissect that. But if we are capable of seeing that the tumor is growing more advanced than our capacities, it is responsible for our part to first inform other multidisciplinary teams and then suggest more focused treatment, because first is the overall health of the patient, and then the aesthetic surgical techniques. So I will suggest that firstly.
Okay, and what limitations could be expected?
Speaking if in our case, or if that kind of complications happens.
In that kind of complication?
First, do an evaluation, surgical evaluation, oncologic evaluation, general surgery evaluation, and see the overall state of the patient, and then finally do the aesthetic surgical approach.
Okay, thank you.
Yeah, it was a nice pictorial presentation. You mentioned that this is the best option with the limited resources available. If that was not the constraint, just imagine, would you have dealt this case differently?
Well, there are a lot of options in terms of plastic surgery. The most safe for the patient and in the setting of a plastic reconstruction perspective will be first approaching to a microsurgical approach. If the microsurgical approach is sufficient and safe for the patient, I would recommend exploring those kind of options first. But we were in a low resource setting, so we try to figure something that works fast and safe for the patient. But in terms of vascular perspectives and plastic surgery perspectives and functional perspectives too, I would like first to evaluate some microsurgical options first.
Would that have affected the prognosis, microsurgical approach?
In functional terms, I don't think it will affect anyway. So as far as we know, the patient is developing really well in terms of function. She is capable of carrying everyday daily life activities without any problems. So I wouldn't think so. It will be more into aesthetic approach, and taking in consideration too that the dorsal part is area in which you need a really well vascularized tissue. So if the defect maybe it's in a position in which you cannot find really good perfusion, that would be the case. But in the case of our patient, we really find really good perfusion, so we weren't worried about that kind of issues.
Yeah, thank you so much.
Thank you for the excellent questions and also answers. So judges, if you may go ahead and use this transition time to fill out your judging response form, and we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. And now we will be moving on to our next presenter, Miss Juliet Clara Scherber from Germany, as well as Kenya, who presents her original research entitled Opportunities for Climate-Sensitive Work in the Health Sector, Kenya and Germany in Focus.
Yes, hello, can you hear me?
Yes, we can hear you, and
Okay.
we can also see your poster, so please proceed.
Amazing. Hello, everyone. My name is Juliette Schreiber, and I'm presenting our study, Opportunities for Climate-Sensitive Work in Health Sector, Kenya and Germany in Focus. So together with Cyrus Kimanti, also present today, we conducted this research in collaboration with the Charité Universitätsmedizin Berlin and the University of Nairobi under the supervision of Dr. Andrea Budnik and Dr. Pamela Godia. So climate change poses major challenges to health systems around the world. It not only impacts population health, but also increases the environmental burden of healthcare itself. Hospitals consume large amounts of energy, water, and materials, making the sector both a victim and a contributor to climate change. In Kenya, the effects of climate change intensify health issues such as malnutrition, infectious diseases, while in Germany, heat waves and air pollution are growing concerns. Both healthcare systems therefore face an urgent need for climate-sensitive and sustainable practices. The aim of our study was to identify and compare opportunities for climate-sensitive healthcare in Kenya and Germany by analyzing existing practices and stakeholder perspectives in two major hospitals, in Kenyatta National Hospital in Nairobi and Charité Universitätsmedizin in Berlin. So our methods, we used a qualitative approach combining field observations and expert interviews. At both hospitals, we observed and analyzed 6 key categories: energy use, mobility, nutrition, waste management, supply chain, and digitalization. In addition to that, we conducted interviews with medical students and hospital staff to explore their knowledge, attitudes, and practices regarding climate-sensitive work. The collected data was compared to identify differences, similarities, and potential strategies for improving sustainability in both healthcare settings. So our results showed that at Kenyatta National Hospital, we found a strong dependence on non-renewable energy resources, such as the daily use of heavy fuel. Although solar panels have been installed, their expansion is limited by budget constraints. Water management is inefficient, with large quantities used daily and no system for recycling or safe disposal. Waste separation exists, but is not followed by effective recycling. So most waste is still incinerated. Mobility presents another challenge because there's a heavy reliance on private vehicles and a lack of pedestrian or bicycle-friendly infrastructure that increases emissions as well. However, the hospital's energy-efficient building design and the use of natural ventilation offer valuable examples of low-energy solutions. At Charité in Berlin, we observed generally efficient energy systems and a strong focus on sustainable building design. Rainwater harvesting and advanced electronic health records contribute to environmental efficiency. Also, public transport and electric vehicle infrastructure support mobility goals. Nevertheless, not all processes are sustainable. For example, food services still rely heavily on individual packaging, and waste sorting remains a problem. So across both settings, staff and students showed high interest in environmental issues, but formal education and structured training on climate-sensitive healthcare were largely missing in both countries. These findings highlight that both hospitals have unique strengths. Germany offers examples of technological efficiency and energy-saving infrastructure, while Kenya demonstrates resource efficiency and practical low-tech solutions adaptable to limited resource environments. In conclusion, sustainable healthcare is not one size fits all. Kenya and Germany each provide valuable lessons for climate-sensitive health systems. Germany's advanced infrastructure can inspire energy efficiency elsewhere, while Kenya's local innovations show how sustainability can work even under resource constraints. The key to progress lies in adapted strategies that leverage each system's inherent strength and promote cross-context learning. Strengthening of environmental education in health professions and integrating sustainability into daily hospital practices are essential next steps towards reducing healthcare's carbon footprint. Thank you very much for your attention.
Thank you for that excellent presentation, Juliet. So now I'm going to be opening the floor for questions from our judges.
Again, I don't know the order. I'll just jump in. Thank you, Juliet. Great presentation. Very interesting, and certainly not something that we would normally associate with each other, right? When you think about these two very divergent health systems. And I think about these global health reports that are out there that have this climate health undertone. I'm thinking here, and love to hear from your perspective, what makes this comparative study between, again, two very divergent systems of Kenya and Germany, what makes that stand out in terms of generating transferable or, I guess, scalable recommendations?
Yeah, so I think it's very interesting to compare two so different systems. First of all, to see also the fears of people that are very different in Kenya and Germany, to also see that the effects are different in Europe and in other countries, to show that climate change impacts already a lot the health of people, for example, in Kenya and less in Germany. And also to compare the methods, how the systems adapt to health, to the problem of climate change, because they can inspire each other in different ways. And both systems had advantages, which was very amazing to see. For example, we visited the kitchen in the Kenyatta Hospital in Nairobi, and there we could see that nearly nothing was packaged. And that was like a big surprise for me, because it was made in one big pot. And I was like, that's something that Germany could copy. And in other ways, for example, the bicycle ways, there was like nothing in Kenya. So I think both systems can learn from each other.
Yeah, interesting. I guess my follow-up question and final question is, we think about those differences. Did you identify any specific institutional or policy level barriers, I guess you would say, that were common to both settings? And if so, how do you suggest overcoming them to implement any changes going forward, especially climate sensitive healthcare policies or changes?
Yeah, that's a good question. And I think we're not about to have the perfect solution yet. But I think education is one of the keys that we want to improve in both countries, because there was like a lack of education for students and doctors and nurses and every hospital staff that did not do the link and the connection between health systems as a contributor for climate change. But I think in both countries as well, there are like not enough people that really have their job in this area and think of ideas, and really the politics and the system must change to make the big differences. We can start with education, but like the big steps must be taken by politics. And that's, for example, in Kenya, it's not easy with corruption and not enough money invested in the change of health systems to improve the for the climate sensitive perspective.
Okay, thank you.
Yeah, it was very interesting study. I found it, as Sir said, from two diverse populations, you had taken out key points. My question was regarding impact of this sustainability practices on maybe medical education or the outcome of medical practices on patients' diagnosis or patients' treatment plan. Was there any drastic difference you noted that because of having certain practices in German, the diagnosis or the prognosis was varied as compared to that in Kenya?
So I'm not sure if I got it completely right, but for example, the diseases that already occur because of climate change are very different in both countries. For example, in Germany, the doctors talked about the heat waves and that like old people need to get hydrated in summer and stuff. And in Kenya, like nearly all our interview partners said that lung problems are already there. So I think and malnutrition and for example, extreme weather events are like more current in Kenya. So I think the diseases that are that are coming out of the climate change problems are very different in both countries and then addressed differently as well. But I'm not sure if that's answering the question.
Yeah, partly. Thank you.
Thank you so much for the questions from our judges as well as the answers from Juliet. So judges, please feel free to take this transition time to submit your judging response form, and we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. We will be moving on to our next presenter, Ms. Karima Bokambaz from Algeria and Lebanon, who will be presenting a case report entitled Leishmaniasis in a Patient with Congenital Neutropenia, a Rare Case Report.
Hello, everyone. Can you hear me?
Yes, we can hear and see you. Please proceed.
Thank you. So as being said, I am Karima Bokambaz from Algeria. I'm a final year medical student, and I'm delighted to present today our case titled Visceral Leishmaniasis in a Patient with Congenital Neutropenia, a Rare Case Report. This case sheds light on an unexpected, unusual, and most importantly, not previously reported infectious complication in a patient with congenital neutropenia. Let me begin with some background to contextualize a bit the case. So, visceral leishmaniasis is a parasitic disease predominantly present in the tropical and subtropical regions of the globe. It is transmitted by it is caused by Leishmania species, which are transmitted by a vector called sandfly. It's more precisely the female sandfly, which will take the disease from dogs and other canids considered as being the reservoir, and then during a blood meal, they will inject it into the human body considered as being the host. It's an accidental host. Its diagnosis typically relies on the recognition of a typical clinical triad of visceral leishmaniasis composed of pallor, hepatosplenomegaly, and most importantly, fever. It's a very typical fever. It's irregular and resistant to antipyretics. On the other hand, congenital neutropenia is a primary immunodeficiency characterized by chronically low neutrophil counts and recurrent infections, among which, as you might guess, opportunistic infections. Most of these opportunistic infections reported in the literature are either bacterial or viral. Parasitic are not predominant, and most importantly, leishmaniasis has never been documented in a report. So our aim in this report was to report this first documented association, and most importantly highlight its atypical manifestation, and therefore help with early diagnosis and management. So regarding our methods, this is a single case analysis, which was supplemented by a targeted search mainly on PubMed to evaluate the data present on the topic using keywords like congenital neutropenia, infectious complication, leishmaniasis, and etc. And we ended up concluding that there were no previously reported association between the two conditions. Moving now to our case presentation. So our patient was an 8-year-old child known with congenital neutropenia, and he presented for a regular follow-up. And during this regular follow-up, we noticed the presence of a pallor and a massive hepatosplenomegaly. And notably, no fever was present. When the laboratory studies were performed, we ended up discovering a pancytopenia with very low neutrophil counts. And of course, obviously, the first suspected diagnosis, the differential to rule out, was leukemia. So a bone marrow aspiration was performed. And here was the surprise. So instead of leukemia, we discovered numerous leishmania bodies inside the macrophage, inside the bone marrow aspiration. And it not only confirmed, but also suggested visceral leishmaniasis at the same time. Afterwards, the patient was administered the treatment of visceral leishmaniasis, which is amphotericin B, which ended up in a progressive clinical recovery and improvement of his blood count. So we believe that this case carries a practical scientific implication. First of all, it clearly illustrates that visceral leishmaniasis can present atypically in congenital neutropenia patients and more generally in immunocompromised patients. So, for example, in our patient, one of the key features of the classical triad, which is fever, was completely missing. So we can say that relying solely on the typical manifestation of the textbooks doesn't apply on this patient population. Second, it highlights the importance of maintaining a broad differential spectrum in immunocompromised patients, especially when they present with organomegalies, unexplained organomegalies, and even cytopenias. And visceral leishmaniasis should be highlighted, especially in endemic regions. Finally, when we review the literature, we notice that most infectious complications of congenital neutropenia are mostly bacterial or fungal, with parasitic disease being exceedingly rare, especially protozoal diseases. So by documenting the visceral leishmaniasis, we highlight and heighten the need to consider these diseases in the differential. So taken together, these observations leads to an important conclusion. It highlights that clinicians should consider visceral leishmaniasis in the differential of cytopenias and organomegalies in immunocompromised patients, even when the classical triads and symptoms are missing. Thank you.
Thank you for your excellent presentation, Ms. Bogenbos. So now we will open up the floor for questions from our judges. I'll have Dr. Mimi go first.
Oh, okay. All right.
Yeah, no. Would you like to go first?
No, I just unmuted. I didn't know what the order was. No particular order. I'll go since I'm unmuted.
Okay.
All right. Excellent. Thank you very much for the presentation. And I must start out by saying the most important thing here. You mentioned you're from Lebanon. I was in Lebanon a few years ago, and I must say the food is fantastic. Anyway, let's get to the real topic. Recognizing that this is a rare case, as you had mentioned, knowing that and recognizing it, how might, though, this case, even though rare, how might it actually inform or impact clinical algorithms or maybe even early screening protocols where both conditions are present and overlap, but may go unrecognized?
Okay, so first of all, they can. Okay, so visceral leishmaniasis is an infectious disease that can occur on any population, not only immunocompromised patients. In this case, it occurred on an immunocompromised patient. So the clinical course is clearly identified. We have first the immunocompromised condition and then an opportunistic infection that occurred on it. So they cannot, the situation where they are both unrecognized is very exceedingly rare. So I wanted to highlight that we first diagnose congenital neutropenia, and the diagnosis of congenital neutropenia is pretty obvious. There is no consensual classification of congenital neutropenia. When we explore it into details, it's pretty specialized. But to be able to suggest it as a diagnosis is pretty easy. It's a low neutrophil count that we can do on regular laboratory tests. So yes, I think. Did I answer your question, or should I go?
No. I think that's it. And I think ultimately what am I asking is who cares, right? I think these are always important questions to take I'm a big believer in the KISS method. Keep it simple, stupid, right? So your approach, so think about clinically, who cares? What's the implication of this? And we think about clinical algorithms, how does that impact? Because as you mentioned, it is rare, So if we are going to diagnose it, we are going to recognize it, even though it may go unrecognized and it's extremely rare that it's the two are overlap. That's what I was just getting you to think about is, have you guys thought about that? But no, it's fine. You answered it. Thank you.
You're welcome.
Yeah, so thank you for the presentation. It was really a rare thing to see in Lebanon. Are you
It
aware
was in Algeria, actually, in
Oh,
Algeria, because
okay.
it also continues somehow the answer that I gave before. In Algeria, even though visceral leishmaniasis is pretty rare worldwide, it has some endemic regions, and Algeria is among these endemic regions. So we somehow always bring it to the table and consider it in our differentials. And on the other hand, primary immunodeficiencies are pretty predominant in pediatric population. So when we, even if in the general population we don't encounter them that much, when we go to pediatric clinics and units, we have a lot of these patients. They are not, of course, all of them are not congenital neutropenia patients, but they are primary immunodeficiencies, which have some overlapping symptoms, including hepatosplenomegaly. So keeping in mind, especially in the endemic regions, that these immunocompromised who generally present with hepatosplenomegaly can have some parasitic infectious disease to be besides the bacterial complications, they can have parasitic complications, among which leishmaniasis is something that should pop some reflexes in the clinical practice.
Right.
In endemic regions mainly.
Correct. So in your patient, you diagnosed it by doing bone marrow biopsy. Are there any sites which can be used for biopsy apart from bone marrow to diagnose leishmaniasis?
Yes, totally. So visceral leishmaniasis, it's the gold standard. The biopsy is the gold standard to diagnose it, and we can perform it on any organ that present with reticuloendothelial cells, including spleen, the liver, and sometimes even the jejunum, if I'm in general population, because sorry, I'm bringing a lot of info together. So in the general population, it can also sometimes affect the digestive system, because as its name suggests, it's a systemic disease. So yes, the direct answer is a bone marrow, spleen, liver, and the digestive system, more precisely the jejunum.
Yeah. What about lymph nodes?
Lymph nodes also, yes, because it's
So,
part of...
so was this patient having, apart from bone marrow, any other sites where lesions were present? Or it was
we
just...
didn't perform it because we already had the diagnosis, knowing that it was a fortuitous discovery. Initially, when we performed the bone marrow aspiration, it was to confirm, to explore a leukemia, because he presented with pancytopenia, and it's the first diagnosis to suggest. And so we didn't expect it.
Okay,
We discovered it fortuitously.
Yeah, I get it. Thank you.
You're welcome.
Thank you so much for the excellent questions and the answers. So judges, we're going to take this transition time for you to submit your judging response form. And now we will display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. And now we will be moving on to our next presenter, Ms. Rania Ahmed from the United States, presenting original research on survival factors in lung cancer patients with mutations in the PROS1, SERPINC1, F2, and F5 genes.
Is Rania Ahmed, and I am a second-year medical student with the Medical College of Georgia in Augusta, Georgia in the United States. And the title of my paper is Survival Factors in Lung Cancer Patients with Mutations in PROS1, SERPINC1, F2, and the F5 genes. And my peers who collaborated with me on this paper who are also second-year medical students are Ryan Brown-Lee, Aditya Birla, Dongyu Zhang, Andy G, Hung Bu, and Mashur Al-Ahmed, and my mentor, Dr. Jurinder Raval, who is a doctor with the Medical College of Georgia in the Department of Hematology and Oncology. So to get started, as some of you guys might know, lung cancer continues to be the leading cause of cancer-related mortality, and it has extremely low survival rates. I think about only 19% in the United States. So the coagulation system is increasingly recognized as a key part of the tumor microenvironment, and it actually influences how cancer cells grow, spread, and evade the immune system. So our research focuses on the intersection between these two systems, the coagulation and the cancer biology. So while clotting disorders are pretty well studied in the context of thrombosis and thrombotic disorders, the same pathways involved in the clot formation also play critical roles in tumor progression, inflammation, and immune regulation. Specifically, the genes that we decided to examine, F2, F5, PROS1, and SERPINC1, all encode major coagulation factors, prothrombin, which is factor 2, factor 5, protein S, and antithrombin 3, which is from the SERPINC1 gene. They're all essential to the clotting cascade, and these genes are pretty well known to drive the hypercoagulable states, but their influence on lung cancer survival and tumor characteristics have not been very well established. So the purpose of our study was to determine whether mutations in these coagulation-related genes are actually associated with overall survival, and key clinical variables, such as like tumor location, race, stage, laterality, and we examine these variables using the Cancer Genome Atlas. And through this analysis, we hope to identify genetic markers that could eventually serve potentially as prognostic tools or even guide personalized therapy for lung cancer patients. So just to talk a little bit more in depth about the methods, like I said earlier, we analyzed data from the Cancer Genome Atlas using both the lung adenocarcinoma and the squamous cell carcinoma datasets. We identified 569 patients with mutations in any of the 4 genes and 850 patients who didn't have any mutations. And like I said earlier, also, we looked at clinical variables like age, race, AJCC, pathological stage, tumor laterality, lobe location, and treatment type. That was all extracted for data analysis, and we applied univariate Cox analysis to assess each of the factors individually, and then applied multivariate Cox analysis to control for confounding factors. But overall, survival was the biggest primary endpoint that we looked at, with hazard ratios and 95% confidence intervals being presented in the results tables, as I'm going to go into detail about. So if you look at these tables, the first 2 under the results bar are the univariate Cox analysis, and then the rest of the tables are the multivariate Cox analysis for each of the different mutations, and only looking at the mutation groups because I believe that was the most relevant results to include. But just to highlight the few key points here, as expected, higher AGCC pathological stage was strongly associated with worse survival, which I would say kind of confirmed our internal validity for the analysis. But we also found several site-specific patterns. The F5 gene appeared protective in tumors of the middle lobe, pleura, and the upper lobe. This could possibly be due to regional oxygenation differences that influence oxidative stress and inflammation. Similarly, PROS1 and SERPINC1 mutations were protective in upper lobe tumors, which may relate to their role in regulating coagulation and inflammation in the tumor microenvironment. In contrast, amongst African American patients, those with the F5 mutations actually had significantly worse survival, suggesting possible interaction between the genetic and environmental or social factors involved in there. And then something important to note here, F5 mutations is pretty rare actually in the African American population. It's more common in European descent. So this was kind of interesting to find. But overall, I would say, finally, one other thing that we saw was right-sided lung cancers with any of these mutations in the F2, F5, PROS1, or SERPING1, all showed poor overall outcomes. The mechanism isn't exactly clear, but the anatomic or vascular differences between the right or left lobes could contribute to this. But overall, the results suggested that coagulation-related genes influence lung cancer behavior based on tumor location, race, possibly local oxygen and immune conditions. So overall, like I said earlier, our analysis indicates that genes traditionally involved in coagulation also influence lung cancer survival. F5, PROS1, and SERPING1 all showed variable effects depending on tumor location and race. And African American patients with F5 mutations had poor survival, which underscores, both biological and health disparity dimensions. And these genes may help refine prognostic tools and guide targeted therapies. But in the future, we do want to, separate the gain and loss of function variants to kind of clarify the distinct biological effects of these genes. In terms of the mutations that we examine, adding data on thrombosis and treatment timing could also help explain survival differences more accurately. And most of all, more personally speaking, I think this is very important, but we also want to validate these results in, larger, ethnically diverse and prospective data sets, but, also looking at how genetic factors interact with social determinants of health. That could, provide a more full understanding of the outcome disparities that we see in lung cancer, and incorporating these findings into race-specific prognostic models could strengthen precision medicine and oncology. And that's all I have today. Thank you so much.
Thank you for that excellent presentation, Ms. Ahmed. We are sad to have missed you. Because she is not here in person with us today, we will be skipping the Q&A. So judges, if you may take this time to please submit your judging response form. As for the audience, we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during today's ceremony, so please don't forget to participate. Thank you. And with that, we will be moving on to our last presenter. Miss Samuka Maluri from Australia, who will be presenting her original research entitled Managing Hyperphagia, Obesity, and Hyperglycemia in Prader-Willi Syndrome, a meta-analysis of GLP-1 agonists and SGLT2 inhibitors.
I'm a second-year medical student at the University of Queensland, and I'm really grateful to have the opportunity to present at this IJMS conference. And anyway, my poster is on managing obesity, hyperglycemia, and hyperphagia in Prader-Willi syndrome. In particular, it's an analysis of GLP-1 agonists and SGLT2 inhibitors. So for some background on Prader-Willi syndrome, it is a genetic disorder that's caused by a deletion, mutation of the paternal 15q11 through 13 region, or it can be caused by maternal uniparental disomy of chromosome 15, where a person has two maternal copies of chromosome 15 instead of having one maternal copy and one paternal copy. And one of the most notable characteristics of this disorder is hyperphagia, or an insatiable hunger, which oftentimes leads to patients with Prader-Willi syndrome developing obesity and subsequently hyperglycemia. And hyperphagia, obesity, and hyperglycemia can be quite difficult to treat. But in recent years, SGLT2 inhibitors and GLP-1 agonists have been shown to be quite effective at treating hyperglycemia in the general population, and GLP-1 agonists have also been noted to cause significant weight loss in obese individuals treated with them. And I wanted to see if these results would carry over into patients with Prader-Willi syndrome. So I started searching various databases such as PubMed, Cochrane Clinical Trials.gov, and Scopus for any trials, and I could only find 2 trials looking into these medications. So I decided to also look into case studies and case series, and I was able to find several. I also decided to look into how I would be able to do a meta-analysis of these case studies and case series. And I find out that it is in fact possible to do a meta-analysis of case studies or case series, and it's a technique that's been used in psychology and medicine. In particular, I chose to do a meta-analysis of raw data rather than any other sort of meta-analysis, just because a meta-analysis of raw data would allow me to specifically gather the data from each and every case study and normalize it into a categorical variable. And the reason I chose a categorical variable was because not all these case studies or case series mentioned the specific reduction in weight or HbA1c. They just mentioned that there was a significant reduction in HbA1c, or that HbA1c levels normalized to went from diabetic levels to levels associated with prediabetes, or they mentioned a percent weight loss rather than giving the number of kilograms, or they just mentioned a significant weight loss without mentioning the amount of weight lost. So to analyze for this variant, I just decided to transform all the data from case studies into categorical variables. And unfortunately, there were very few case studies looking at SGLT2 inhibitors, either alone or in conjunction with GLP-1 agonists. However, there were a significant number of case studies that looked at GLP-1 agonists. In particular, a very large number of GLP-1 case studies found that GLP-1s help with weight loss and hyperglycemia in a significant number of cases. But there are also a significant number of cases where GLP-1 agonists do not help with glycemic control or weight loss. While the initial analysis of case studies on GLP-1s was promising, you have to remember that there were only around 35 case studies that looked at weight loss and 28 case studies that looked at HbA1c control in patients treated with GLP-1 agonists, and that case studies are not an unbiased representation of the general population with a disorder. There's a tendency for positive results to be published as case studies and negative results to not be published. So we also want to look at what the clinical trials say. There were only 2 clinical trials that looked into GLP-1 agonists and their impact on weight. One of the trials also mentioned HbA1c, but the results were not significant. The other trial did not mention HbA1c, so the meta-analysis of this only concerns changes in BMI. And the reason there are 3 data points is because one of the trials mentioned the results, different effect sizes for the results in children and adolescents. So that's why there are 3 data points, because in the original trial, there were different data points for children and adolescents. And as you can see in this, the effect sizes in all of these trials of looking into the impact of GLP-1 agonists on BMI were non-significant, and the error and the overall meta-analysis summary of the random effect analysis was also not significant, unfortunately. So overall, this study was very interesting just to look at all of the results, and there are definitely some indications of promising results, such as the case studies showing a significant number of patients losing weight and getting better glycemic control after the use of GLP-1 agonists. But we need better types of data, and in particular, since the 2 trials looked at older GLP-1 agonists, liraglutide and exenatide, which tend to have smaller weight loss effects than more recently released GLP-1 agonists like semaglutide and tirzepatide. It would be very nice to have future studies that look into the impacts of the newer GLP-1 agonists and to see if they perhaps have a larger effect on both weight and glycemic control in patients with Prader-Willi syndrome. Very recently, there has also been a new drug called diazoxide choline that has been released to help treat hyperphagia in Prader-Willi syndromes, and it has very promising results, but it can also cause hyperglycemia. And since GLP-1 agonists and SGLT2 inhibitors are glycemic control drugs, I think future trials that look into the combinations of diazoxide choline and SGLT2 inhibitors and GLP-1 agonists would be interesting to see if SGLT2 inhibitors and GLP-1 agonists can maybe offset the hyperglycemia caused by this new drug to treat hyperphagia. Thank you.
Thank you so much for that excellent presentation, Ms. Mallory. And I am happy to report that she is in here with us as well, so she can answer some questions. So I will now open the floor for questions from our judges. Either of you can go first as well.
Okay, I'll go first then. Nice presentation in a rare disorder, how the glycemic control can be achieved. I was curious, is there any data to reflect upon glycemic control by GLP-1 analogs in obese patients and in obesity due to Prader-Willi syndrome? How it is different, I mean to say. Controlling obesity in general, people having high BMI without Prader-Willi, and in the patients of Prader-Willi.
Well, I guess in patients without Prader-Willi syndrome, there have been a large number of recent trials done on GLP-1 agonists and SGLT2 inhibitors, and generally most research indicates that GLP-1 agonists and SGLT2 inhibitors are fairly effective at controlling glycemic control in many patients. And GLP-1 agonists in particular also, to some extent, reduce appetite and cause obese patients to lose weight. But in Prader-Willi syndrome, Prader-Willi's is often associated with hyperphagia that develops, and patients with Prader-Willi's engage in food-seeking behavior, which means oftentimes their guardians have to lock all cabinets or fridges to prevent patients with Prader-Willi's from engaging in hyperphagic behavior. So any sort of medication that would help treat obesity in patients with Prader-Willi's would also to some extent have to treat the hyperphagia associated with the disorder.
Thank you. That's it.
I was waiting for the order. I didn't know if I was supposed to go first or second, so that was my delay. But great presentation. Thank you very much. I guess I should be culturally sensitive and say good day, right? Anyway, I used to live in Australia, so very familiar with that. Hey, great presentation. And I'm curious, you think about, you mentioned GLPs, which I thought was an interesting aspect of this. And given the popularity and growing anecdotal and clinical significance of GLPs globally in both obesity and metabolic disease in general. How does the analysis and your analysis in this study position GLPs in the context of PWS?
Well, I think my overall analysis shows that there's some promising evidence, but another thing I noticed is I couldn't find any case studies looking at newer GLP-1s, like the newest GLP-1 to come out, tirzepatide, and I'm really hoping that in the future there will be both trials and case studies looking into that just to see whether or not it corroborates the other studies that look into this drug on other patients in the general population and also has promising results for patients with PWS. As far as I know, there has been one clinical trial registered that's recruiting patients that's looking into the effect of tirazepide on patients with PWS, but that trial is ongoing and actively recruiting patients.
Yeah, because that was my question. I was really going to, and you alluded to it, I was just going to ask, and maybe you could touch on it. What steps do you think should future studies, and thinking about, again, we think about the next generation GLPs, but even the ones that are either under investigation currently in clinical trials, and there's a lot of them, but even the current ones out on the market, what steps should be taken, do you think, to strengthen clinical recommendations in PWS, just based on what you've seen so far?
I would like to see more case studies and trials looking at the combination of SGLT2 inhibitors and GLP-1 agonists, just because even though there was like a very limited number of case studies into that, some of these case studies were very promising. And also, like I mentioned earlier, very recently, there has been one drug approved to treat Prader-Willi syndrome called diagon choline that has helped with hyperphagia-related behavior. But like I mentioned, one of the concerning side effects is hyperglycemia. And hopefully there will be like trials or case studies looking at how SGLT2 inhibitors and GLPs, including older GLPs, can maybe help treat that, could potentially maybe help treat the hyperglycemia that we see associated with this new drug. Maybe the drugs will work synergistically and the effects on hyperphagia will compound.
Excellent. Thank you.
Thank you so much for the excellent questions and the excellent answers from our presenter. So judges, please feel free to take this transition time to submit your judging response form, and we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during the ceremony coming up shortly, so please don't forget to participate. Thank you all very much. And this concludes all of our oral and poster presentations. A heartfelt thank you to all of our presenters for the past 2 days for their outstanding work, and all of our judges from the past 2 days, as well as our current sessions judges, Dr. Estesham, Dr. Dyer, and Dr. Nini, for their time and thoughtful feedback. We will now take a 10-minute coffee break while we calculate the final scores and prepare for the award ceremony. So please take this time to stretch, refresh, and return promptly. We'll be starting our award ceremony right after the break. Thank you, and we'll see you shortly. Hi, everyone, and welcome back. We are about to begin our award ceremony, but first, it is my pleasure to welcome Dr. Francisco J. Bonilla-Escobar, Chief Editor of the International Journal of Medical Students. Welcome, Dr. Bonilla-Escobar.
Good morning, good afternoon, good evening, everybody. As we close the 4th edition of the IJMS World Conference of Medical Student Research, I want to take a moment to reflect on everything we have experienced together during these 2 days. We began with a powerful series of oral presentations, followed by a rich collection of virtual posters, representing an extraordinary range of scientific inquiry. What we saw today and yesterday is a testament of the creativity, rigor, and global vision of early career researchers. This year's presentations come from dozens of countries across 6 continents: Australia, India, Pakistan, Nepal, Turkey, Serbia, Ecuador, Germany, Kenya, Guatemala, Ukraine, Palestine, United States, Colombia, and many more. The diversity of our presenters reflects something very important. Medical students research is not a local phenomenon. it is a global movement. The themes we explored were equally broad and meaningful. We saw advances in sleep medicine, cardiology, endocrinology, mental health, infectious diseases, oncology, public health, and ophthalmology. We heard systemic reviews and meta-analysis, retrospective cohorts, basic science models, randomized controlled trials, public health interventions, and rare case reports that push the boundaries of what students can achieve. We saw work addressing refugee mental health, community outreach for KA students, climate-sensitive health strategies, drug treatment demographics, AI performance in medical education, diabetic retinopathy biomarker, toxoplasmosis, and neurological complications of major diseases. Many of these topics mirrors the world's most urgent health challenges, and it is inspiring to see students leading these conversations. To all of our presenters, thank you for bringing your science, your ideas, and your courage to share them with the world. Your work elevates the standard of medical student research, and it reminds us why this conference exists. I am pleased to announce that all presentation videos will remain available on YouTube, and we will soon upload timestamps for each talk, so you can easily share your individual presentation with mentors, programs, and collaborators. In addition, the World Conference of Medical Student Research 2025 abstract book, containing every accepted abstract, will be published shortly. Each abstract will receive its own digital object identifier, ensuring that your work becomes a permanent, citable contribution to the scientific record. As we look ahead, the World Conference of Medical Student Research continues to grow and evolve. Next year, the conference will be held mid-year, which we hope will better support those applying for residency programs. We will also begin certifying e-participants to strengthen online engagement, and we plan to add a public question and answer segment to make the conference more interactive. Before we conclude, I want to express my sincere gratitude to the people who made this conference possible. To our director, Chloe Carrington, thank you for your leadership and vision. To Hannah Cavill, who managed all logistics with precision. To Camilo Agames, who has always helped us with the streaming platform. And to Elaine Liang, our Master of Ceremonies, who guided us smoothly through every session. Thank you for your dedication. I also want to thank our conference abstracts reviewers, the student editors of the IJMS, who worked tirelessly behind the scenes to ensure the scientific quality of this event. And finally, a special thanks to our judges. What an extraordinary panel of experts we had this year. Your time, your expertise, and your thoughtful evaluations elevate the World Conference of Medical Student Research to a higher standard. Thank you. I'm incredibly proud of what this team has achieved. This conference is a reflection of your commitment, your effort, and your belief in the importance of medical student research. Every year, this event becomes stronger, more global, and more impactful. And that is because of you, medical students of the globe, your work, your participation, and your belief in the value of early career research. On behalf of the International Journal of Medical Students, thank you for being part of the 2025 IJMS World Conference of Medical Student Research. We hope this conference inspires you to continue your scientific journey wherever they might lead. We look forward to seeing you again next year. Thank you so much.
Thank you for your inspiring remarks, Dr. Bonilla-Escobar. And without further ado, the moment we've all been waiting for, the award ceremony. I'm delighted to announce our award winners. Our awards are divided into two categories: highest scoring abstracts from the abstract revision process, evaluated by our abstract review committee, and scores from the oral and poster presentations delivered during the conference. Please note that any presentation where the presenter was not present for the full duration, including the question and answer panel, or required us to play a pre-recorded video, as well as presentations that did not follow the submission or presentation instructions, were unfortunately excluded from the final scoring process. To begin, I'd like to recognize the highest scoring abstracts from the revision process. In third place, we had a four-way tie in no particular order. Our four awardees are, first, National trends reveal hypertension as the dominant driver of cardiovascular readmissions by Kyle E. Thurman, Trisha G. Mukherjee, Joseph G. Danton, Paul T. Kang, and Michael D. White from the United States. Second, exploring careers in healthcare and Onward, or ECHO, a community outreach program to promote healthcare career interest in K-8 students surrounding the CU Anschutz Medical Campus by Ariel Davydov, Rebecca Alschler, Zoe Van D. Voord, and Amy Poog Bernard, also from the United States. Third, assessing the precision of AI-generated medical answers, an evaluation of Llama 3-powered Meta AI by Ariba Khan and Muhammad Taha Khan from Pakistan. Congratulations to our 4 winners for 3rd place. And now in 2nd place, during the abstract revision process in the original research category, we have evaluation of anxiolytic effect of pantoprazole on Swiss albino mice, an experimental study by Farheen Koliyatil, Sweta Open, and Jacob Abraham from India. Congratulations. And finally, in 1st place, with the highest scoring abstract for original research during the abstract revision process, is ease of nasogastric intubation using a frozen nasogastric tube by a novice intern in anesthetized intubated adult patients of randomized controlled parallel assignment study by Madhuri Domaraju, Shamim S., and Saloka Samatare, also from India. Congratulations to all of our winners. Now moving on to the case report category during the abstract revision process. In 2nd place, we recognize avoiding pacemaker, resolution of sinus node dysfunction through CPAP therapy by Rebecca Iona Roos, Irina Maria Russo, Maria Cristina Simeon, Bogdan Valentin Rose Novan, and Paula Cornea Varga from Romania. Congratulations. And in 1st place for case reports, the highest scoring abstract is aggressive gallbladder carcinoma in a patient with Down syndrome, a rare presentation by Bashir Baba, Malik R. Hroub, Lana M.A. Jamal, Salah Haldeen Deeb, and Khalid Al-Hashamoun from Palestine. Congratulations. Now moving on to the oral poster presentation category. In 2nd place, we had a 2-way tie. In no particular order, our 2 awardees are first, aging patients, changing substances, unexpected demographic shifts in Turkey's drug treatment admissions over a decade, presented by Aisha Sila Kumtupi and Dr. Levent Ozdemir from Turkey. Congratulations. And in 1st place for the best poster presentation, who is the highest scoring presentation, is Cross-Sectional Study on Air Pollution and its Influence on Health-Related Quality of Life in Coimbatore, presented by Dr. Dharani Dharmajod from India. Congratulations to our winners. And now moving on to the full oral presentation category. In 4th place for best oral presentation in the original research category, based on our judges' scores, we recognize vagus nerve neuropathy and SARS-CoV-2 infection, an ultrasound study by Helena Micek from Serbia. Congratulations. And in 3rd place, we have effectiveness of haptic feedback devices in reducing pain perception during intra-articular corticosteroid injections in rural Guatemala and Kenya, a randomized controlled trial presented by Tyler Perlberg, Alpha Felipe, Carmen Tong, Jordan Constanti, and Gautam Desai from the United States. Congratulations. In 2nd place, we have evaluation of anxiolytic effect of pantoprazole on Swiss albino mice, an experimental study by Ms. Farheen Kotayatil, Sweta Okhman, and Jacob Abraham from India. Congratulations. And in 1st place for best oral presentation in the original research category, we have association between diabetes mellitus and intraoperative awareness during general anesthesia, a retrospective cohort study presented by Nakbik Nguyen, Zhang Hao Wang, and Eduardo Esperidian from the United States. Congratulations. And now for our final category, the most liked research presentation as voted on by our audience members. With a grand total of 483 votes, this award goes to cognitive impairment and its influencing factors among elderly at residential homes in Western Tamil Nadu, a cross-sectional study presented by Sri Tapnasi SK from India. Congratulations to all of our award winners. We will be emailing your award certificates to you shortly, and you will also be featured in our next editorial, along with an invitation for fast-track publication in the International Journal of Medical Students. Congratulations again, and we are so thrilled to be able to celebrate your work. As we conclude this year's conference, I want to similarly extend my heartfelt appreciation to every presenter, judge, reviewer, and attendee who have made these past 2 days so incredibly meaningful. Your passion for research and your dedication to advancing medical knowledge truly embody the spirit of the International Journal of Medical Students. We hope this conference has inspired you, connected you with new peers, and encouraged you to continue pursuing scholarship throughout your medical careers. Thank you all once again for joining us, and we look forward to seeing you at next year's conference. Thank you all so much.